timely, isn't it?
Yeah. Already it is
Doctor, I got message from Dr. Ramani madam that she is stuck up in a cesarean, so she'll be delivering her talk a bit late on the 3rd or 4th number. So Sahiti, please start the session.
Good evening, respected dignitaries and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on NCD Summit KOGS with Tamilnadu Societies. Let me welcome the program director of the webinar, Dr. Kanchan Sharma ma'am. Ma'am is currently the director and chief consultant of Akash IVF Center Kanpur, secretary of Kanpur Obsgyne Society, president of IHRF Kanpur, ART specialist, laparoscopist, and colposcopist. Ma'am has a numerous number of awards like Foxy Achiever Award, Pratigna Social Impact Award, and Nari Suraksha and Nari Samman Award, and a Lifetime Achievement Award from KOGS Kanpur. Ma'am has recently organized a mega event, WWNatCon. So with this short introduction,
I'm the candidate for chairperson NCD committee, Foxy.
Yes.
That is the main introduction I present. So stop sharing. Good evening. Thank you for the nice words. Remembering that Almighty God, I, Dr. Kanchan Sharma, give regards to one and all respected learned faculty, presidents and secretaries of different societies from Tamil Nadu and Kanpur. Our chief guest, Professor Dr. Meera Agnihotri Madam and Dr. Revati Janki Raman Madam, both very learned, visionary and inspirational national leaders. Our guest of honors, our present very efficient, visionary and loving Vice President from Tamil Nadu, our Dr. Sampath Kumari Madam. Our most visionary past Vice President, Dr. Anita Singh Madam, Dr. Kiran Pandey Madam, Chairperson Medical Education Committee, Dr. Usha Goenka Madam, President KOGS. I am highly obliged by the presence of our knowledgeable and wonderful speakers who are great academicians who have accepted my invitation and are ready to enlighten us with their bundle of knowledge. Our brilliant speakers of the day are Dr. Sampath Kumari Madam for GDM, Dr. T. Ramani Devi for hypertensive diseases of pregnancy, Dr. J.M. Kanan Madam for lung and pregnancy, and moderators of the panel, Dr. Charmila, and on the thyroid disease and pregnancy with her experts, Dr. Aruna and Dr. Chinmay Ratha. All wonderful chairpersons and panelists, I welcome you all. Please accept my heartful thanks and gratitudes. We start our session with the prayer of God and the lamp lightning. Thank you. After God's blessing, I welcome our chief guest, Dr. Revati Janki Raman, Madam from Tamil Nadu. Madam is an epitome of love and knowledge from Tamil Nadu. Many times, whenever I called and talked to you, ma'am, I hear only words of blessings from you. You are a classical sitar player and academician And Madam, for you, I can say that you have created your academic and spiritual growth. Kindly bless us with your words of wisdom. You are the vice president. You were the vice president Foxy South Zone in 2016, and now President TNFOG 2023. You were the founder, secretary, and the past president of Madurai OG Society, and founder president of IMS Madurai Menopausal Society, and you received Foxy Dr. Durusha Community Service Award, and you are the recipient of Lifetime Achievement Award of IMA Madurai, and selected as Master Trainer for PPIUCD program by Foxy, by Figo Foxy, and you are the author of Foxy Focus on Amniotic Fluid A to Z. And you are the Pride of Foxy Award in November 2019 at Mumbai. Madam, we need your blessings, words of blessings. Please bless us.
Thank you, Dr. Kashin, for your very kind introduction. And I thank you very much for inviting me to this very important scientific session. As we all know, non-communicable diseases, that is NCDs, kill 41 million each year. This is really a huge number worldwide. And it is equal to about 71% of all deaths globally. Of this, the cardiovascular diseases account for 17.9 million. Most of the NCD deaths are because of the cardiovascular problems, followed by cancer 9 million. And next is respiratory diseases 3.9 million, and diabetes around 1.6 million. Actually, more than diabetes, the respiratory diseases causing the death is even quite higher. And today we have got very important topics on all these things, like cardiovascular disease is going to be dealt with by Ramani Devi, GDM by Dr. Sampath Kumari, and respiratory diseases by Dr. Jayam Kannan. And we know that tobacco use, physical inactivity, and harmful use of alcohol, unhealthy diet, all these things are very, very important risk factors leading on to death from NCD. And the diet is very, very important. I'm happy that Dr. Kanchan is taking up that part also to discuss. So avoiding all these avoidable risk factors, along with screening, detection, and treatment of NCDs, as well as palliative care, are the key components of management of NCDs. So nowadays our focus is shifting more towards management of NCDs, and it is really an apt time to have a CME like this. And I congratulate Dr. Kanchan for organizing such a wonderful CME, and I wish this CME a grand success. Also, I wish Kanchan success in this forthcoming election as chair NCD committee. Also, my best wishes to other candidates from South, Dr. Jayarani Kamraj, Dr. Kalpana, Dr. Aruna Suman, and Dr. Selva Rani from Nagarkoil. So I wish all from South, Kanchan also gets elected in this election, and hope to see the results positively next week, 25th. Wish you all the best. Thank you.
Thank you, madam. We are really obliged by your wonderful words of blessings. Thanks, ma'am, for blessing. Now, our second chief guest, our own Dr. Meera Agnihotri, madam. I welcome you and request to give your blessings by your loving words. Madam, I am very small to speak about you. I have learned and being always inspired by you, ma'am. You are my guru ma, and each step I take only by holding your hand, ma'am. Ma'am, you have led successfully collaborative group of 13 organizations supporting Foxy position state meant to the Ministry of Health, Government of India for COVID vaccination to lactating and the pregnant women. You have organized Shapat 1000 for National Health Program, and you were the organizing chairperson of WWNetCon. Just we had very successful conference. Anything to speak about you, just सूरज को दिया दिखाने के बराबर है मैडम. Please bless us with your words of blessings.
Thank you, Kanchan. Hello, thank you, Kanchan. Thank you very much. Am I audible?
Yes,
Am I audible now?
Yes,
Madam, bless us.
At the outset, I extend my heartfelt gratitude, love, and blessings to the organizer, Kanchan, for
Thank you,
holding such a important meeting on the subject which is very much in need of hour and demand of time. And I am really elevated, feeling happy to share the dais with Revati. My love and blessings. I know Revati is very learned. We will be just chairing this session and holding the session, and with the success goes to the speakers. I will like Kanchan or anybody to repeat the names of the contestants so that it may be revised over here. Kanchan is contesting for non-communicable diseases, and she has worked very, very hard since a very long time. And I wish God must help her, and we must celebrate it as Revati was telling on 25th. Please also narrate. Revati has narrated some and she has missed one or two.
Dr. Jayrani is there.
Dr. Jay, please raise your hand, darling.
Ma'am,
Madam,
Jayrani Kamraj
Kavita
here, ma'am. Jayrani Kamraj, Kavita is here.
Kavita is
Kavita
here.
is there. Kavita is there, and Dr. Aruna Suman is there, and
Kalpana is there, ma'am.
Aruna is not visible.
Kalpana is there, ma'am.
Ma'am, good evening. I'm traveling, ma'am. Now and then
Okay, doesn't matter. So best of luck for
Thank you, ma'am. Thank you for your blessing, ma'am. Thank you so much. Your words are very much strength and strong for us, ma'am.
Thank you, madam. Thank you for your blessings, Asirvad. You are so senior. So I think your blessings will must take turn.
My heartfelt blessings to all of you. Or just watching your faces and your excitement, everything, it is very heart touching. Friends, today's meeting is very, very good. And the speakers are really very learned. I mean, every back home message will be an important one for everybody else, because most of them I have worked with and I have delivered lectures or I have chaired sessions, and I know that they will be doing. J.M. Kanan is not visible, but only a couple of days back we have conducted a very important session, just like the keynote address in my conference with the, she's not there, I believe she has not come as yet. Sampat Kumari, I know that we have been working together. So we know that we are sitting with the, you see, encyclopedia of obstetrics and gynecology. So that is what I can say. And whatever they will speak, my dear friends, whether you are contesting or you are not contesting, I'm pretty sure you will be going back with very many back home messages which may be existing in your heart, but they will come true when you work with them. So I extend my heartfelt gratitude, love, blessings and everything to Kanchan. आप अपने सब दोस्तों को 25 तारीख को those who are contesting के साथ we will celebrate the success, and that is what I can extend like this. Thank you very much for making me a part of this meeting. Kiran Pandey has joined. All other persons I can't see whether they will be joining late or I don't know. So, but my blessings, love will be there. I will be joining after half an hour. I have to have some work. And if in between I'll join, please pardon with me. I will be joining in between. Thank you very much.
Thank you, ma'am. Thank you, ma'am. Thank you for
your wonderful
blessing us,
words
ma'am.
of
Thank you,
blessing.
words.
And we are obliged by your gracious presence and lovely words. Thank you very much, madam.
Revati, can I leave? Yes. Yes, she wants to tell something, Revati.
Yes, madam.
No. Mr. Kavita's name while I was mentioning. I wish her all the best.
Thank you, madam. Thank you. Madam, you missed my name, so we need your blessings, madam.
Oh,
Thank
yes.
you.
Yes. So you were not visible earlier. Now you are visible.
Yes.
Okay.
So our guest of honor, our own Vice President, Dr. Sampat Kumari, madam. anything in her praise is less. The words are less when I say anything about her. She is always very loving, always blessing. Whenever I met, she always give me suggestions, and I always appreciate and follow, ma'am, your suggestion. Recently, you have organized wonderful vice president conference in Kodaikanal, and ma'am, a lot much of regards and congratulations to you. You are at present the Foxy vice president. You were the Senate member of TN Dr. MGR Medical University, national corresponding editor of the journal OG of India.
Leave it.
Madam, so many awards and everything in your credit. Today we will also hear your wonderful lecture about GDM. You are invited for your words of blessings.
Thank you, Dr. Kanchan, for the
Thank
opportunity.
you, madam.
And as our chief guest, Dr. Meera Madam and Revati Madam told, I wish all the best for all the contestants. And you have organized such a good webinar with the Tamilnadu societies and Kanpur societies, which is the need of the hour. Diabetes, hypertension, lung and pregnancy, and the panel, everything. As Meera Madam told, the delegates and the faculties can take a best take-home messages from this webinar. And I wish you all the best, and all the contestants, I wish you all the best.
Thank you, madam. Thank
Thank
you
you,
for
ma'am.
your lovely words of blessings. I'm always obliged, madam. Please go on giving me suggestions.
So next,
Whatever, yeah, I do. Our other guest of honor is Dr. Kiran Pandey, madam, the chairperson of Medical Education Committee. We always say her that, madam, you are a beauty with brain, and she always advises a right thing. She is there always with us in our society, and madam is a ICOG Governing Council member also. She was a immediate past HOD of GSPM Medical College Gynae Department, and she won many national, international awards and many published
Thank you,
papers.
Kanchan. Thank you,
Madam, you are most welcome to give us blessings here.
Thank you, Kanchan, for very kind words. I know you love me, and the same is here. So definitely our feelings do get shared. I'm really honored to be the guest of honor. I don't know I deserve it or not, but here the dais with such learned persons, Dr. Revati, Dr. Meera ji, ma'am, हम लोग की सबकी godmother हैं, and she is वो always with us. Dr. Sampath is there, Dr. Jem Kanan, who has probably not joined, but she will be there. And so many of the learned speakers. I'm really very honored to be and privileged to be the part of it. And the very good thing which I've seen in last two of your programs, that you amalgamate beautifully the speakers from every corner of the India. So the जो unity in diversity वाला जो हमारा 15 अगस्त वाला है, that is what you fit it everywhere. North, south, east, west. I mean, you take out the gems and put it them in, involve them into the webinar. So that's really wonderful. Everybody gets benefited. And the topics which you have chosen, the GDM, maybe it's hypertension, maybe it's a respiratory diseases, all are actually, we are facing a lot, maybe because of so many factors, and which we will be discussed by the speakers, how to, because now they have taken a toll over the other communicable diseases, the morbidity and mortality, both are very, very high. So they have to be discussed. So I'm sure all the speakers are waiting and the audience is there to listen to them, the key pearls of wisdom. And just before that, I want to share everybody's view. We are waiting excitedly, eagerly, but confidently of all of you, success of you. You are doing a lot of the work for a very long time. You have been totally devoted for it. So I'm sure you will be 100%. Jairani has been doing wonderful work. Dr. Kalpana is there. Dr. Silva is there. Dr. Kavita is there. I hope I'm
Aruna
not missing.
madam.
Sorry?
Aruna madam. Dr. Aruna madam.
Okay, yes.
So,
Definitely, I wish you all the success, and I'm sure your hard work and the interest and passion with which you want to serve the Foxy will be there, and we will be, in fact, because I am also there at the moment, and I will be there, so we will be also benefited. Together, we can even do more work. Like with a like-minded person, you can do more and more educational work and for the benefit of each and every member of the Foxy, so that it can reach to the last person of the Foxy. And those who are not members can also become interested and come forward. So with these words, I would say I'm thankful to Kanchan and to all of you to make me the part of it. And we are all eager to listen to these our learned speakers. Thank you very much. All the best.
Thank you, ma'am.
Thank you for
ma'am.
wonderful words. Rather,
Well,
we are obliged by your gracious presence, and you have taken time out of your busy schedule to bless us. Thank you,
Yes.
madam. We are really
Thank you, madam.
obliged.
Thank you, madam, for your gracious
other
presence and for your
chairpersons-
blessings to
Thank
us.
you.
Thank you so much.
Other chairpersons are Dr. Anita Singh, madam. I think she has joined.
I have phoned her, but she's not picking
She is
up.
the
Kanta
past
madam.
vice president.
She's not picking up. I don't know.
Dr. Usha Goenka, madam. Have you joined? दोनों ने ज्वाइन नहीं करा है. So coming on the we are just missing their words of blessings. I think they are busy. So starting with the academic session, our first topic is on GDM. So the brilliant speaker for this topic is our own Dr. Sampath Kumari madam. The chairpersons are Dr. Jyoti Sundaram madam. She is MD OG and FIC OG, Professor Department of Madurai Medical College. She is a senior consultant of Mitra Hospital, Madurai, President Madurai OG Society, and member MTP Committee Foxy, and 4 times Best Doctor Award from the District Collector and from IMA. Presented many research articles in the high risk of obstetrics, and her field of interest is high risk obstetrics. Madam, you are welcome. You are there?
Yes, ma'am.
Yes, ma'am.
Am I audible?
Yes, madam, you are audible. You please rename yourself, madam. The
Okay,
second chairperson is Dr. Sundar Narayan. Is he there? I welcome you, Dr. Sundar Narayan. You are MD and you are a gynecologist and fertility specialist from the SS Fertility Center, Nagarkoil. You are a course director of postdoctoral fellowship in gynae endoscopy, Dr. MGR Medical University. You are at present the president of Nagarkoil OG Society. Sir, are you there? You are most welcome as a chairperson. The third chairperson is Dr. Rashmi Ajit. Madam, you are there? Dr. Rashmi Ajit. She is MD DGOA and Senior Assistant Professor. She is Secretary of Nagarkoil Obstetrics and Gynae Society. Madam, you are most welcome. The fourth chairperson is Dr. M. Chandra Ponnaswamy. Madam, you are there? She is obstetrician and gynecologist and IVF specialist and consultant Chandra Nursing Home and Fertility Center. She was awarded the Best Doctor Award by IMA Women Achiever Award and Best Fertility Consultant Award. Madam, you are most welcome. Now I request the first chairperson to kindly introduce Madam Dr. Sampath Kumari. Madam Dr. Jyoti,
Yeah,
please introduce.
She lost the connection.
Yeah. Yes.
Yes, Jyoti, madam.
Yes, Jyoti madam already introduced.
It's a pleasure to introduce our dear Professor Madam.
Yes, sir. Yes, Jyoti madam. Here.
She is traveling throughout India for, the earlier for another health camp. Okay, on GDM, it is defined as the glucose intolerance of variable degree and onset during pregnancy. And this condition is associated with the persistent metabolic problem. So we are more bothered about this GDM because it affects the maternal health as well as the perinatal health. She is going to deliver a talk on GDM. Welcome you, ma'am.
Thank you, madam. Thank you, madam. Thank you, Jyoti madam, for the nice words and Kanchan for the opportunity. And all the seniors, colleagues, and my friends. I'll share the screen. Yes. You can see the screen. Jyoti madam, screen terida?
Yes,
Yes, madam. Very good.
Okay.
Right.
So this is good evening to all. This is the case which everyone would have seen in their practice. 30 years gravida 2 with the reports of GCT at 24 weeks on regular checkup is 160 milligram. Vitals and other parameters are normal and per abdomen examination is 22 to 24 weeks corresponds to the LMP. As all of us know, this is a case of gestational diabetes mellitus. So as Jyoti madam told, what is gestational diabetes? That is the diabetes that can develop during pregnancy. Previously, we thought as 20 weeks, but nowadays it is a little earlier also. That is due to which can lead to the metabolic disorder in future. So in India, almost we follow the screening test of DIPSI guidelines. What is the DIPSI guidelines? 75 gram of oral glucose administered with 300 ml of water and the blood sample is taken after 2 hours. If the value is less than 140, it is normal. If it is more than 140, we consider them as the gestational diabetes mellitus. This test is followed invariable of the diet. It can be the fasting or it can be with the breakfast, whatever it is. But only thing is 2 hours after the glucose, we are going to see the blood sugar value. So this screening test as per NHM, it is done 3 times. First, ideally at 12 to 16 weeks. And if the value is normal, then it is done at 24 to 28 weeks. And again, if it is normal, it is done at 32 to 34 weeks. In most of the center, they do only 2 times. But in our Tamilnadu government, the government of guidelines is to do for 3 times. So what are all the other screening tests? So normally we follow the DIPSI guidelines and there are other ACOG guidelines with 50 gram of OGTT. Fasting is 135. After 1 hour, 180, 2 hours, 155, and more than 3 hours is 140. Carpenter and Coston, WHO and Diabetic Association. Though there may be lot of methods for the screening, but it is better to follow universally the DIPSI guidelines because the blood sample is taken only once and the patient need not to be in the fasting in the pregnancy period. So how are you going to follow up this patient? So once the blood sugar value is taken, if it is more than 140, we consider them as per guidelines. That is, if it is, we go with the medical nutrition therapy for 2 weeks and after that we repeat the fasting and postprandial. Fasting should be less than 120 and 90 and postprandial should be less than 120. If it is increased, then we consider them as the diabetes and follow the treatment. So how most probably now we are starting, some people are giving metformin. Most of the time during pregnancy, we start with the insulin. What is the medical nutrition therapy? We recommend complex carbohydrates, 3 meals and 2 snacks to limit the glucose fluctuations. And the ideal caloric distribution between carbohydrates and protein is not yet known. This is the carbohydrate plate, which will tell total fat of 25 gram, calcium 600, iron of 21 milligram, protein 60 to 65, carbohydrate 300 gram. This is the way we counsel. Take some carbohydrate diet, some fruits, some vegetables, some pulses. So this carbohydrate diet plate has to be given to all the GDM patients. And the exercise at least a minimum of 30 minutes or at least 10 to 15 minutes. Brisk walk we don't advise, a small walk, whatever it is. So the moderate intensity of aerobic exercises will reduce the incidence, will reduce the complications. That is, at least it reduces the dose of insulin. So this food habits, that is the medical nutrition therapy, is most of the time it is itself will reduce and make the sugar value under control. So from the day of conception till delivery, the euglycemia should be followed. That is, fasting should be less than 90 and postprandial should be more than 120. So how are we going to, if it is increased? Insulin dose. Insulin dose, previously we considered that 0.7 in the first trimester per kg and 0.8 units per kg in the second trimester, third trimester 0.9 and 1 units per kg during the term. So depending on this, the insulin value is calculated. Normally, how are we going to give the insulin is, now suppose if you are going to give 8 units, 2/3 should be 9 units. We will take that as a 9 units. So 2/3 should be given in the morning and 1/3 is given in the evening. That is 2/3, 6 units in the morning and 3 units in the evening. In the morning, we give the ratio of intermediate, regular and intermediate acting insulin in the ratio of 2:1. That is, if at all, if it is 6 means we give as 4:2 in the morning. In the evening, we give in the equal ratio of intermediate acting insulin and short acting. That is 1:1. This is the way we give the insulin. So depending on the sugar value, 2 units can be increased. So fasting value is increased means night dose of intermediate has to be increased, or a regular insulin has to be given in the morning. So whenever you give the insulin also, the MNT, medical nutrition therapy, is also to be followed. So normally we give the insulin in 30:70 premix. That is the human insulin mix. It is given before breakfast, but normally what I will tell, you make ready the breakfast and have the injections and start. So sometimes we follow that 0.7, 0.8, 0.9 and 1. Otherwise, with the blood sugar value, depending on this, if it is 120 to 160, to start the dose has 4 units. And if it is 160 to 200, add 2 more units, 6 units. More than 200 means 8 units. For every 20 milligram of blood glucose, you add 2 units. Then correspondingly see the fasting and postprandial blood sugar. Fasting value is increased means night intermediate has to be increased, or a regular insulin in the fasting has to be increased. If postprandial is increased means you have to increase the intermediate insulin of morning doses. If at all needed, the third dose in the afternoon can also be included. So it doesn't mean that we have to refer the patient to the diabetologist. We ourselves can adjust the insulin doses. These are all the available insulins: rapid acting, short acting, intermediate acting and long acting. Normally we don't prefer long acting, but nowadays there are incidences with the IVF center and other corporate hospitals. Long acting insulin is also used. That is, the analogs are also used. So these are all the sites. You should counsel the patient. So if you are a diabetes, what complications can happen? So you have to have the insulin injections daily. Suppose the patient is on PCOS and she is on metformin. The metformin dose can be considered, can be continued. But if the sugar value is increased means insulin dose has to be added. Rather than increasing the metformin dose, the insulin dose has to be added. Still, we don't know the side effects of the baby with the metformin. So the sides, thigh and abdomen, hand, these are all the regions where the front and the back, the insulin can be administered. We should counsel the patients to have the own insulin. As I told earlier, the rapid acting insulin, Nova Rapid and Humala, some IVF centers and some corporate hospitals are using, and it also has the same value. There are studies which tells that comparison between metformin and insulin insulin alone. Whatever it is, the dose, and nowadays the metformin is also used by many people. But at the side of most of the time, there are studies which tells that with the larger doses of metformin, there are incidents of growth restrictions in the baby. So how are we going to monitor the antenatal care? Normally, we have that the 20 weeks, we decide that it is a GDM. And every 4 weeks, we have to repeat the scans, 24 to 28 weeks, 28 to 30, and 34 to 36 weeks. That is, with a gap of 3 to 4 weeks, the ultrasound should be done to identify the macrosomia from the abdominal circumference and the amniotic fluid. As with the GDM, big placenta, so there may be amniotic fluid index may be enclosed. Fetal biometry also has to be done once in 4 weeks. So before 20 weeks of pregnancy, a fetal anatomy, that is the we are doing the anomalous scan at 18 to 20 weeks and then follow up at every 4 weeks with the ultrasound and the biometry. So monitor the abdominal fetal growth macrosomia at every antenatal visit. As all of us know, this is the Pedersen's hypothesis, maternal hyperglycemia, which leads to fetal hyperglycemia, which produces fetal hyperinsulinemia, and fat deposit in the shoulder. That is the reason we end up with the shoulder dystocia. The complications are during the antenatal. There are 5 to 10% of PAH, macrosomia, and the polyhydramnios because of the big placenta and the urination from the baby. During the labor, due to the big baby, the prolonged second stage, shoulder dystocia, and gastrointestinal tract injuries is possible. And postnatally, big baby, big placenta, amniotic fluid increased. There is a possibility for postpartum hemorrhage, subinvolution, lactation failure, and infection is also possible. So these are all the diabetic complications, but they are very rare with GDM. Ketoacidosis 2%, diabetic retinopathy and nephropathy is very rare, but hypoglycemia, as well as the hyperglycemia. Hypoglycemia is also dangerous. So we have to tell the signs and symptoms of hypoglycemia to the patient. So this is the shoulder dystocia. If you don't suspect, these are all the procedure. Bring the patient to the end of the table and do the McRoberts maneuver, give the assistant to give the pressure, and go inside and rotate and do the internal maneuvers. These are all with the post-shoulder dystocia, but you should be always have in mind that shoulder dystocia can happen to the macrosomia baby and in the GDM. So what are all the complications with the baby? Sudden IUD normally at 3rd trimester, preferably at 38 weeks, and respiratory distress because the lung maturity is delayed. So if you are going to give the steroids, the insulin dose has to be increased. Hypoglycemia, if the sugar after the delivery of the baby, sugar value is less than 44, we have to give the IV fluids, and the calcium, if it is less than 9 milligram, IV calcium should be given till the value is normal. You can go with the syrup calcium also. So hypomagnesemia, hyperbilirubinemia after 48 hours, the phototherapy is needed, and the polycythemia. These are all the biochemical complications that can happen to the baby after the delivery. So the short, these are all the short-term complications for the mother and the baby. Long-term complications being 50% of the patients can go for GDM in the next baby, and they can go for type 2 diabetes and the metabolic disorders in futures. And for the baby can go for PCOS, GDM, obesity. The cycle will be routine. So the diabetes, the adolescent, from the adolescent itself, diet and exercise has to be counseled. That's the way we can reduce all complications during the pregnancy. When are we going to deliver? GDM pregnancy doesn't mean that if the sugar value is under control, you can wait till 38 weeks. If the sugar value is not under control, if the patient is having the high dose of insulin, 60 units, 70 units, you can terminate it earlier. But if it is under control, you can go with the 39 weeks. And the GDM is not an indication for LSCS unless other obstetric indications are present. Always we prefer for the vaginal delivery, assess the baby weight. If it is a macrosomia more than 3.5 to 4 kg, then you go for an LSCS. LSCS should be done for obstetric indications only. On the day of labor, what are we going to do? So now night insulin has to be given. The morning dose of insulin is withheld, and you have to take the fasting blood sugar. Depending on the blood sugar, the rate of normal insulin has to be added. If it is 90 to 120, there is no need for insulin. 100 ml per hour of normal saline has to be added. If 20 units milligram is increasing, as I told earlier, again 4 units can be combined with the 500 ml of normal saline and 100 ml per hour. That is 16 drops. 180 means 6 units, more than 180, 8 units. Depending on that, we are going to add the IV insulin, that is insulin in the IV fluids, 500 ml. Once the baby is delivered, almost the sugar value will be normal. So how are we going to follow up? So GTT is done after 6 to 12 weeks. The follow-up is very, very important to reduce the metabolic problems and the type 2 diabetes in future. And after 6 to 12 weeks, every year the patient has to be followed. Now we have a study with Dr. Seshaya sir, who tells that the GTT can be done on the 3rd day. 3rd day itself, fasting and postprandial blood sugar, and you can monitor. So 70% can be diagnosed on the 3rd day itself, because the patient may not come back after the 12 weeks. Then you have to do the again GTT at 6 to 12 weeks and every year. So 50% of the GDM, as I told, can go for type 2 diabetes. So the HbA1c is normally needed only in case of pre-diabetes, and normally it is not needed for the diabetes patient. So once the patient is discharged, you have to talk about on discharge, about the contraception method also, barrier method, progesterone monthly pills after lactation, and avoid OC pills. Even the intrauterine contraceptive devices can be advised. There is no, though there is an incidence of infection, but it's not common with the IUCD. So in a Gravida 2 or Gravida 3, the permanent methods of sterilization and even the vasectomy can be advised. As a finally, counseling, the GDM patients has to be counseled about the complications of the mother and the baby, Diet and exercise is important, self-monitoring of blood glucose and administration of insulin, and the signs and symptoms of the hypoglycemia. The physical activity has to be advised to the patients. The take-home message is screen all patients of the GDM with the DIPSI guidelines and monitor carefully with the fasting and postprandial, and accordingly you have to adjust the insulin. And delivery is individualized. It doesn't mean that you have to go for LSCS, and institutional delivery preferable. Suppose if you don't have the facility of ICU and if you don't have the facilities of blood bank, better it go to the institutional delivery or where the facilities are available in the corporate setups. And refer as early to avoid the complications to prevent from the litigations. Thank you. Once again, I thank Kanchan for the wonderful opportunity, and thanks to all. Thank you.
This was very clear-cut message and very, very informative session.
Yes, very nice.
To the chairperson, Dr.
Very
Jyoti,
simple
for
and
the
crisp. Madam, very simple and crisp talk.
Dr. Jyoti, will you summarize?
Yeah, I will do. It is a very crisp talk. Thank you, Sambat Madam. So we have to do universal screening for all pregnant women, usually by DIPSI method. Medical nutrition are very important in the treatment of GDM. There's perinatal complications in each and every patient, and you should be ready to treat it. In well-controlled GDM patients, routine delivery prior to 39 weeks is not at all recommended. And vaginal delivery is the preferred method of mode of delivery. And you have to follow the patient in postnatal period also, and you have to rule out type 2 diabetes. So thank you so much, Sambat Madam.
Thank you.
It was very, very informative. Thank you.
Thank you, madam.
Thank you, madam. Really
Thank you,
informative,
Meena, madam.
and we are
Thank you,
obliged. Dr. Meena, madam, will you want to give some comments? You are muted, madam. You are muted.
Very good presentation. Excellent presentation.
Thank you, madam.
As was expected.
Thank you. Thank you, madam. Thank you so much. I have to come to your house. I'll come.
Madam, we are obliged. You really
Everything
made
put in
us.
nutshell. That is very, very important. All points are brought, but within this short presentation. So very
Crisp and clear message, very clear
Thank you,
message.
Renuka.
We have heard so many talks of the GDM, but this was really wonderful and summarizing all in a very short.
Jayam Kannan madam has joined. Introduce Dr. Jayam Kannan madam. Next talk.
Good evening, ma'am. Jayam madam, good evening.
Welcome,
Kannan
dear
madam.
madam. We are obliged by your presence. You are always epitome of knowledge. And madam, you always teaches us a very good lesson and always ready to provide us the bundle of your knowledge and enlightening us always. The topic chosen by you is wonderful, that is lung and pregnancy. And our chairpersons are Dr. Shanti Rani. Madam, you are there, Dr. Shanti Rani, madam? She is there?
Madam, she is held up in some emergency, ma'am.
She's held up in emergency. She is the professor and HOD, and at present, she is the president of Thani Society, and a founder treasurer of the Thani and OG Society. She has got many awards. You are most welcome. The second chairperson is Dr. VH Vanita Rukmani. Madam, you are there?
Yes, ma'am. Yes, ma'am.
Oh, welcome, madam. Welcome. You are most welcome here. You are the secretary of Thani Obstetrics and Gynae Society. Madam, you have done MBBS from Madras Medical College and DGO from Stanley Medical College and MS from Thani Medical College. You have been their speaker and organizing secretary for Foxy meetings of Thani and presented papers in many state and national conferences and published many papers. You are most welcome here. The third chairperson, Dr. Radha Madhvi, madam, you are there?
Yes, ma'am.
Oh, most welcome, madam.
Thank
You are the founder, president of Thiruvannamalai OG Society. You are the director of Rajam Multi-Specialty Hospital and director of Rajam Institute of Paramedical Sciences. At present, you are a joint secretary and EC member of TNFOG. And you are a practicing gynecologist since 1994 and conducted 3 annual conferences and got many awards and published many papers. You are most welcome, madam.
Thank you. Thank you, ma'am.
Dr. Gayatri, madam, you are there? Dr. Gayatri, madam, are you there? She's not there. She is a fellow in reproductive medicine and director of Hari Fertility Center through Vannem Valley, and she is the secretary and delivered first IVF baby. And madam, you are welcome. Now I request our chairperson, madam, to introduce Dr. J.M. Kanan, the speaker of our next session, Pregnancy and the Lung. Dr. Vanita, madam, you are muted.
Yes, ma'am. It's my pleasure and I'm honored to welcome our madam, Dr. J.M. Kannan. She was the best committee awardee of Foxy Adolescent Health Committee in the year 2013 to 2015. And she is the emeritus professor of Tamilnadu MGR Medical University and managing trustee of Garbharaksha Ambikai Group of Institution, director of GFC Fertility Center, Trichy and Chennai. And she has been the vice president Foxy 2018. She's a free legal aid.
Manita, everyone in down south know me well.
Yes, ma'am.
Thank you. Thank you. Thank you for introducing me.
Madam, we have 2 words of praise for you. Whenever we call you, you are there to give us your knowledge and always take a wonderful lecture, ma'am. We are obliged by your presence.
Thank you. I hope I do justice also today.
Yes.
Kindly allow me to share my screen.
Please share.
And to respectful Meera Agnihotri, the doyen of Kanpur, and to the entire North. From Meera, I learned how to prepare slides when this time I came to your conference. She makes slides so crisply and powerfully. I thought, even if I am not doing all the slides so powerfully, at least 1 or 2 slides, I should make it powerful. So, Madam Meera Agnihotri, this slide which I have made is my humble submission to you from down south. And from all down south, we bless, greet.
One line, Jam, can I add 1 line for you?
Yeah.
Whatever is written for your this thing, everybody knows more and more than what is being written on this thing. So Kanchan, just convey everybody that whatever is written, just multiply it 100 times and that is J.M. Kanan.
Thank you, madam.
Right, madam, right.
Thank you. So the entire presentation of mine and the first slide of mine is humble submission to Professor Meera Agnihotri, who has done decades of work, more than 6 decades of work in Kanpur, such an interior area, which is now getting developed. From the airport, I can see how much of suffering you people should be undergoing to come out and do anything. From that place, Kanchan Sharma wants to come out, and I bless her and greet her on behalf of all the Tamil Nadu and South people, and expect her to get into the flight every day and go out and deliver her messages to all Foxians and come up to the highest standard in Foxy. Okay, with this, let me thank my chairpersons, Vanita, Gayatri, this is Radha and others, and start my topic on, this is a topic of communicable diseases. They say, in obstetrics, which are coming up to be the 3rd important cause of maternal death. So in that, if you think of the communicable diseases, I never thought of anything else except lung, because the lung which we don't look into it can be disastrous, which has been seen in COVID time. Kidney, of course, we will be able to make it out by the urine output, but lung, because dyspnea is such a common manifestation in pregnancy, everybody who is dyspneic think, yes, she is trying to look more uncomfortable. She is trying to do some presentation. That is how people are taking up. So that is the one which we have to avoid. And respiratory diseases too, even small one in pregnancy, should be given a care, because out of this 27 million deliveries which are going on in India, think of this 2% which are going to be admission into the intensive care. So every 50th person who is delivering throughout the country is getting admitted into the ward. Of that, if you take hypertensive disorders in pregnancy, it is going to be 6%, which is all the more complicated. And out of the admissions in the respiratory unit, ICU unit, I found that 10% of patients are really near miss. Not because the obstetrician has been careless, it's because they have been near miss, could not be done anything. But with good treatment, 85% come out successfully. Only 15% stay for a long time in the ICU unit or succumb to the problem and make this family a motherless child with family. Respiratory system, we all know well, undergoes anatomical, physiological, and biochemical changes. The plasma carbon dioxide pressure rises, bicarbonate goes up, arterial pressure oxide, and oxygen consumption comes down. All because the distended abdomen is raising the diaphragm to a higher level, and instead of making a normal figure, it is making a little oblique. And this is the result of this. But not only this anatomical position, there's also this position of the pulmonary circulatory system, which is going to be the main cause of this problem. The vascular volume getting increased, getting passed through the lungs and goes into the, pass through the heart, goes into the lungs, produces capillary pressure high in the lung. This, along with the hypertension, which is more prone to produce acute pulmonary edema, preterm delivery, in which unexpectedly the heart is overloaded, the heart immediately shunts itself to the lungs, and the lungs, which is already in a state of difficulty, if it is a general anesthesia, goes into problem, and the fluid which is non-restrictively given can also worsen these cases. And postpartum, in order to control the pain of the patient, we give anti-inflammatory drugs, which also promotes this capillary pressure. And all these changes, along with the sudden hemodynamic deterioration, which occurs immediately after the delivery, is a cause for many of the pulmonary problems. Right. If you get a pulmonary problem in the theater, let me say first, before we go to the other things. In the theater, I have done a delivery. I have delivered the child. Placenta is removed. Patient was 180, 120 blood pressure. Now, suddenly, anesthetic is fine. The sp2O2 level is going down. The patient starts frothing out from the mouth. And the doctor anesthetist is in a gaze. She says, "Madam, I am getting acute pulmonary edema. Please help me. I want some more hands." What she wants to start oxygen therapy immediately. Somebody has to have a control over the fluid so that they give not more than 40 to 50 drops per minute and intravenous furosemide with good oxygenation. And somebody has to do the central venous monitoring. For that, central venous monitoring is the one for which anesthetist immediately demands. In a tertiary care unit where the cesarean is being done in the daytime and there are people around to take care with postgraduates and others, things becomes easy breaking a nut. But here it becomes breaking a coconut. And the reduction in the afterload, with the use of vasodilatation and nifedipine and hydralazine, all these things add to the problem. And unless it is efficiently managed within the next 5 minutes with adequate doses of furosemide, proper suction and immediate intubation, the patient usually succumbs to this problem of acute pulmonary edema, which many of us face in the theater during a cesarean for a hypertensive disorder. Now, back to the anatomical changes. Yes, the anatomical changes are not only in the structure, but also in the small functional effects like increased vascularity, mucosal friability, excessive secretion. And all these things are done by the estrogen, because estrogen is the one which produces maximum vasodilatation, capillary congestion, hyperplasia, along with this enlarged uterus, along with this hormonal changes of estrogen and progesterone also, because progesterone also produces loss of muscular relaxation. And with all these things changes with the lungs, the changes are going on, but the diaphragm may be altered in its shape, but the function of the diaphragm always remains constant. The lung volume, everything reduction is a physiological change which we are attributing to this pregnancy. But all these things, compliance, naturally reduces the lung function. If there is a trigger to this problem, it worsens the patient's condition. The hyperventilation and tachypnea and tachycardia and all this hyperrespiratory alkalosis have to be taken care appropriately if the patient says, I am breathless. Normally, any patient who is pregnant, we may find her dyspneic, but she will not tell that she is breathless. But if she says, I have difficulty, it should be immediately attended by all person neighbor to the patients. The blood volume also adds to this. The blood volume increases more than 50%. The plasma volume increases, but the red blood cells are not going up. It is only 20 to 25%. With the result, there is a incorrelated increase in the volume. Patient is anemic, and this anemia is going to constitute a good problem for the oxygen carrying capacity difficulty, and that is also going to give rise to problems. And all these problems are mainly faced between 25 weeks to 36 weeks. By 36 weeks, when the baby from the under the xiphisternum comes down and falls flat, with which we are happy that your patient is going to be soon with us for delivery. By that time, the lung also gets a little relaxed. And the pulmonary function tests, which have been done in many cases, have shown all these changes with the vital capacity, with the inspiratory capacity, and total lung capacity, with the minimum alteration in the total lung capacity, whereas the vital capacity is the one which produces maximum changes, which has been noted about 75 years ago. So the dyspnea in a patient who is pregnant is 60%, and it may be more when she has got a exertion. A pregnant woman at 32 weeks cannot walk with the Kanjan Sharma, who can walk faster. That is the difficulty, an example. Because I know Kanjan Sharma is a very brisk person. And at rest, Kanjan Sharma will be aramsely sitting. But even at rest, this patient will be little dyspneic. The physiological dyspnea, which occurs, may not interfere with her activities. She may not say, I am not able to do this, I am not able to do that. But still, it has its own limitation. So the patients have to be given advice about not doing heavy work, heavy exercises, but not to make the patient sit as an inactive person. Why is it? My last slide will give you that point as a take-home message. The physiological dyspnea, in spite of all these difficulties, kindly note the chest is clear and there is no VC. Dyspnea, non-associated with any wheezing, is a physiological dyspnea in pregnancy. If there is a small cooing rhonchi, that means the patient is not all right and it is a pathological dyspnea. The pathological dyspnea, mostly if it starts in the early trimester, it continues in the second trimester. The patient always will say, you are all right, ma, at every visit. She will say, I am all right except for my cough. because the cough which comes at the time of 20 weeks will never disappear until it delivers. And if she is having this cough, ask her not to take a supine position, take a little slanting position. And if there are cardiac signs, we have to be very careful and give her a cardiologist support also. What are the types of failure these sort of normal patients who are having more dyspnea go in for is? One is ventilatory failure due to all these problems of hypertension and other things. The second one is hypoxemic cardiac ventilatory failure. The hypoxemia and the cardiac the existing alterations also makes lung secondarily fail, and that leads to a lot of problems taking us by surprise not to think of this amniotic fluid embolism. The one which is commonly we see in pregnancy is a patient who is already asthmatic going in for pregnancy. We all know when the asthmatic, the bronchioles, which are normally like this, the bronchioles are like this. So these things may get better, all right, in the daytime. Most of the asthma are also exposed more to problems in the night times. The lung functions may be all right for her asthma. Only thing is, whatever is the trigger that she has to be avoided strictly. We have to record the triggers for her and advise her to take medications appropriately and ask her not to allow asthma to flare up. And we have to tell her that it has its impact on the baby. The asthma in the pregnancy, most of the patients become all right. 30% of the patients may become little uncomfortable, but still manageable with the drugs. Other 30% are the one which go in for problems, especially if you are seeing between 24 to 36 weeks. What are the problems? It is the problem on the mother going in for all the hypoxemic problem. On the part of the baby, a preterm delivery, intrauterine growth restriction, increased prenatal the problems and postnatal problems also. Now, patient has come at 10, 11 o'clock in the night with acute status asthmaticus with pregnancy. That is another condition which we have to think of in all asthmatic patients, not in the regular patient alone. Even in pregnant patient, we should be able to see it more. What we should do immediately as she comes, comfort her with a proper position, with the salbutamol, with other this inhaler, nebulizer, other things, and think of the steroids at the end only. Because the steroid, if it is started, if she finds that a comfortable thing, she herself will start taking steroids at home, and that will have a long-term effect on the baby. The oxygen saturation and the other things should be maintained in all these asthmatic patients near to 98 SpO2. Theophylline and deriphyllin group have got a very limited role for these patients. So the asthmatic patients, if they are persistent, the environment has to be kept proper. Shock-active beta agonists should be thought over, and cortisone also must be given as an inhaler. Cortisone not as a tablet or injection, because the systemic effect of these things are more compared to the inhaler one. So it is better to give her as a puff rather than as a tablet or as a parenteral dose. The next one which have is common cold and flu. Influenza is one thing which we think treated, it lasts for 7 days, untreated lasts for 1 week. In pregnancy, treated or untreated, it lasts for more than 6 weeks. Because already the hypervolemic lung and the mucosal system puts her into a lot of problem. And H1N1 should always be suspected in all patients who are resistant to antibiotics, and the cough continues, because the fear of pneumonia should keep us to it. And these are the patients with cough, they go in for low birth weight, preterm delivery, and all other complications also. Tuberculosis in pregnancy, we have efficiently managed tuberculosis in many parts of our country, but still, in the present scenario, we are still seeing tuberculosis patients. Even 2 days ago, I saw a patient with tuberculosis, not only pulmonary tuberculosis, she also has got bone tuberculosis, spine tuberculosis. I was really astonished. Engineer's wife coming out with this and blaming the engineer for not being at home and taking care of her. This was such a pathetic state. And these patients, now we are not able to give streptomycin. We have to give them on the INH, ethambutol, and rifamycin. And this takes a little longer time for them. And though the drugs cross the placenta, there is very low risk of problems. And these patients go in for a lot of problems after delivery. Exacerbation of tuberculosis is very common, and they have to be given proper care. By a chance, postpartum, 8 months or 10 months after delivery, the child is found to be having tuberculosis. Giving the drug to the mother will not support the child because the drug is not excreted to that in the breastfeed. The child requires to be treated by separate way in a nursing infant also. We have some drugs which we give commonly for any patients with pulmonary problem, that is cough drugs. Cough preparation, bromoxin, not been established for its efficacy in pregnancy medications. Acetylcysteine not looked at. Ambroxol is also not established. So we do not have any of the common cough syrup ingredients which have been titrated for a better use in pregnancy. So whatever we use is rough and ready one with not much of this evidence-based work which we are doing. Then coming to this pulmonary hypertension, hypertensive disorders, going in for problems, along with the other one that we have to notice, molar pregnancy. Molar pregnancy, we always find that the patients go in for pulmonary hypertension. Even it's a benign molar or choriocarcinoma, the lung is the first system to be affected. And in any molar pregnancy evacuation, one has to have a deep concentration on the lung also. Pneumonia, I have already said, and if you are not looking into the H1N1 problem properly, we land with lung abscess, and that is going to give rise to many problems, including chorioamnionitis and sepsis in the newborn also. The amniotic fluid embolism, the dreaded complication about which every one of us is well read, well aware, but our hands are tied because it has got about 80% catastrophe. It usually occurs in labor and immediately after delivery, or even with any uterine manipulations also can occur. And the amniotic fluid circulating in the vascular circulation goes into the pulmonary system, and it produces so much of flare in that, and it results in the left ventricular failure. And many people have talked about amniotic fluid embolism as a separate entity, so I am not taking it as a problem of communicable diseases. The mechanism by which it produces is very clearly shown here with the entire block in both the they say right side and left side. Totally alveolar system is put into a trash. Then the problems of all these things, pulmonary edema, whatever is treatment which I have said in the beginning, do you have the pulmonary edema treatment which is different from the pulmonary edema treatment of a pregnancy? Not at all. Whatever is the pulmonary edema treatment which is being done in any ICU for any non-pregnant female is the one which has to be allowed in the pregnancy also, with liberal use of furosemide and central hemodynamic monitoring. Acute respiratory distress syndrome and pregnancy. Yes, pregnant patients are at risk of this complication, and they are also not different from a non-pregnant one. The treatment also has to be the same way as it is any pregnancy one. The fetal risk is the one which has to be noted whenever any therapy is given for ARDS in pregnancy. However, in a 28 weeks pregnancy, if she is going to be treated for ARDS, which I have done in a couple of patients and got them recovered after 6 weeks, there the paramount importance is given to the maternal condition and not to think of the fetus. However, if you can avoid a drug, alter the drug, and it is preferable to keep that in the same. Always in these cases, maternal oxygen saturation is the most important key that has to be mentioned, and alkalosis should always be avoided. Survival is always similar to ARDS in the general population, if only we give a keen care for this ARDS in a good HDU or ICU setup. Sleep apnea and pregnancy. This is also a known entity. That is why many of our elders will ask patients who are pregnant not to sleep in the erect posture, not to sleep in the supine posture. So this is also one thing which we have to note because of the already existent plasma volume problem, blood volume problem, and the respiratory restrictions. Sleep apnea is also one thing one has to be very careful. I talked in the beginning about the healthy pregnancy lung function. Why they see? It has been found that patients who has been just sitting, eating throughout her pregnancy has shown that the 3-month-old baby has got lower lung function. All women who have been sitting ideally and not efforting their lungs properly and doing breathing exercises properly, the children have been found to have a low lung function in the first 3 months. As we are getting more knowledge on fetal origin of adult diseases, we should tell all these asthmatic patients, patients who have got a known case of lung problem, or they have been repeatedly having respiratory difficulties, please tell them that their exercise is very important if they want a baby which is going on adequately well after birth. That is lung capacity of the baby, which is very, very important. That is why many of the babies are going in for persistent respiratory problem after delivery due to the continued low oxygen supply in the mother onto the baby. Thank you very much for this patient hearing, giving me the opportunity to Kanchan. Wish her a grand success, a great success, and also to Dr. Meera Agnihotri, madam, who has been the pillar behind this CME as well as pillar behind Kanchan Sharma. Thank you, ma'am.
Thank you very much for your excellent talk. We always appreciate you as a epitome of divine purity and dedication and perseverance and lot of energy and time which you devote to your work. Madam, your talk was wonderful and gave us a lot much of knowledge. Thank you for your gracious presence. Over to chairpersons for the sum up.
Good evening, madam. Thank you.
Dr.
Good
Radha
evening.
Machi, madam.
Good evening, madam. Thank you for this opportunity. Wonderful NCD webinar. And Jayam Kannam, words fail me to tell about her enough. Madam makes everyone so interested in any subject she presents. She's a guiding light to all of us in the South. And about lung disease, it hides in plain sight. Out of mind is out of sight. Most important organ for life is lungs, which we realized with COVID. COVID, even the common man knows what is oxygen carrying capacity, SpO2, everything. And madam, thank you so much. And Kanchan madam, you're sure to win. All the best again to you. And
thank you
very much, madam.
Thank you.
Now, Dr. Ramani Devi madam is there. Madam, most welcome. In spite of being so busy with the cesarean section, you are so sincere, madam. You have given me message, and now you are again there to enlighten us with your wonderful talk. I always heard about that is very important talk, and we get lot much of knowledge by your this talk. And again I wish to hear these type of wonderful talks. That is the hypertensive disease of pregnancy. Our chairpersons are Dr. Jaymala. Dr. Jaymala, are you there?
Yeah, very
yes,
well.
ma'am. Welcome our chairperson. She is a consultant obstetrician and gynecologist, infertility and gyne laparoscopic surgeon. She is the assistant managing director, Rainbow Hospital for Women and Children, Salim. She is at present the president of OG Society of Salim. Madam, welcome. You have gained very much of academic excellence, worked at many places, even in Ireland from 2000 to 2009. And you got the ultrasound training at fetal medicine unit and got so many awards. Presently, you are the consultant at Rainbow Hospital, Salim. And got many awards from Foxy. Welcome. The second chairperson is Professor Dr. L. Shanmuga. Yeah, Doctor. And Madam, you are there?
Yes, ma'am. Yes, ma'am.
Welcome, Madam. Welcome, Madam. You are the Professor, Department of OG Government, Mohan K. Medical College Hospital, Salim. You are the Secretary of Obstetrics and Gynae Society of Salim, and 16 years of appreciable service to your medical field. And you have published indigenous articles in national and international journals, and special interest in the field of high-risk pregnancy and endoscopy. Madam, you are most welcome over here. The third chairperson, Dr. N. Derani. Madam, you are there?
Yes, ma'am.
Achha, you are welcome here, madam. You are the consultant obstetrician and gynecologist, Jai Maruti Hospital, E Road, and you have done ultrasound training even from the Sonoscan Coimbatore and MBBS MS. You at present are the E-Road secretary and have the 13 years of experience in obstetrics, and your area of interest is high-risk obstetrics and ultrasound. Our fourth chairperson, Dr. Uma. Madam, you are there, Uma Binder?
Yes, I am here, ma'am.
Yes, madam. Welcome. Please rename yourself. You have done MS and from Thanjavur, working as assistant professor, Department of Obstetrics and Gynae, Government Raja Mira Sudhar Hospital, and presently secretary of Thanjavur Obstetrics and Gynae Society. Your area of interest are high risk obstetrics. Madam, you are most welcome here to chair the session of a brilliant speaker, Dr. Ramani Devi. Madam, please, Dr. Jaimala, introduce our brilliant speaker, Dr. Ramani Devi. Madam.
First of all, thank you, Madam, concerned Madam, for inviting us to this enlightening webinar, and all the best for your tenure, and we are hopeful that you'll win this election. Thank you so much. And Dr. Ramani Devi, madam, like, she doesn't need any introduction, but for the people who, from the north, I think I will elaborate her academics. She's a managing director from Ramakrishna Medical Center and Janani Fertility Center. She has won 10 gold medals during UG and PG period, which is very evident. Which will be very evident from her talk. And she's a chairperson endometriosis committee of FOXI 2014 to 2016. She's a Women of the Year Award by Bharatidasan University in 2013. She received Women Achievement
Take it
Award.
short, just as a national VP, that's enough.
Yes, she has lots of awards in her, in her kitty. So I would like to invite Dr. Ramani Devi, madam, to enlighten us on hypertensive disorder and pregnancy, which is a although we have a lot of teaching going on this, still, I think it is one of the leading causes for maternal death. And I think we have to enlighten our juniors also. And I prefer, like, our community also, we have to strengthen our community on this aspect. Yeah, with that, we welcome you, madam.
Welcome.
Yeah, thank you, Jayamala, for the nice introduction. And first of all, I should congratulate Dr. Kanchan Sharma for having arranged this excellent webinar. And my best wishes to you for your success in all your future endeavors. Hypertensive disorders of pregnancy is quite a vast one, but I will try to condense as far as possible. See, basically, I have made my presentation based on the guidelines of Canada 2018, and then ACOG Practice Bulletin Guidelines, and Hypertensive in Pregnancy Diagnosis and Management by NICE Guidelines. And finally, we should not forget our own FOXI Gestosis ICOG Guidelines, where it's still, I think, the Gestosis score that has been given up by the this particular GCPR is an excellent model to identify who are at risk. So my talk will be based on the diagnosis, classification of HTP in pregnancy, pathophysiology, evaluation of newly diagnosed hypertension, investigations to diagnose severe disease at an earlier stage, management, and conclusion. So let me start with the introduction that HTP is the most common medical complication of pregnancy. In India alone, 12 to 22% of the women have HTP, and the incidence of preeclampsia was found to be 10.3 according to the National Eclampsia Registry in the year 2013, and 18% of the MMR is because of hypertensive disorders complication, and it is the third cause for MMR. So why we are so much bothered about preeclampsia or hypertensive disorders rather are because it has got its impact upon both the fetus and the mother. Upon the fetus, it leads to growth restriction, preterm delivery, placental abruption, respiratory distress, cerebral palsy, retinopathy of prematurity, necrotizing enterocolitis, sepsis, stillbirth. On the mother, it causes permanent hypertension in future, cardiovascular disease, cerebrovascular disease, kidney injuries, chronic renal disease, and end-stage renal disease, liver failure, cardiomyopathy, CNS damage, stroke, seizures, and diabetes. So when it comes to the question of hypertensive disorders of pregnancy, we should get alerted because it may be a forerunner for a future onset of all these medical complications. So that is why we have to bother about this. So then comes how to, first basic thing is how to measure blood pressure in a proper way. We have to make the patient sit comfortable, and then use the correct size cuff. It should be placed on the wiring that is connecting to that of the BP apparatus should be on the medial side, and it should be parallel to the brachial artery. And we have to have a slow digital pressure. As you release, it should be close to the nearest of 2 millimeters of mercury. And then the diastolic pressure at corresponds sound 4 and 5. Suppose if you don't have a sound 5 at a level of 70 or 80, then you need to go for a level 5, which is sometimes seen only at 0. And if the blood pressure is 140/90, maybe you need to recheck it at least 4 to 6 hours apart. But if it is 160 to 110 millimeters of mercury, the second reading should be taken at least 15 minutes apart. Suppose if the patient is not able to sit comfortably, maybe she can lie on the left lateral recumbent position, and we have to check the blood pressure. So now coming to the classification, International Society of Systolic Hypertension classification, this hypertension in pregnancy can be classified into hypertension that is occurring less than 20 weeks or more than 20 weeks. And when it comes to a question of less than 20 weeks, it could be chronic hypertension or a white coat hypertension where the pressure rises only when she sees the doctor, and otherwise it may be normal. And masked hypertension is the one that when the doctor takes the blood pressure, it may be normal, but when at the rest of the time there may be hypertension. And these sort of patients, you have to have a ambulatory hypertension monitor, 24 hours ambulatory monitor, which can pick up whether it is a masked hypertension or a white coat hypertension. Then again, the chronic hypertension can be essential or secondary. And when it comes to the hypertensive disorder that is diagnosed after 20 weeks, it could be a transient gestational hypertension or a gestational hypertension or a preeclampsia, and anything with a super added thing can happen. And if you get convulsion, then we term it as eclampsia. Pregnancy-induced hypertension is basically gestational hypertension where there is blood pressure is beyond 140/90, no evidence of underlying cause of hypertension, no associated symptoms, and comes to normal within 6 weeks. This is very important. But whereas in preeclampsia, it could be either non-severe or mild or severe. We don't have a moderate one. And the eclampsia is anything where you have the convulsions and the coma. Okay, then when there is associated proteinuria, it has to be graded as trace +1, +2, +3 based upon the proteinuria there. Then in pregnancy-induced hypertension, you can have, that is in preeclampsia, it can be early onset or a late onset. Early onset preeclampsia is the one which is very dangerous, where we get the blood pressure rising before 34 weeks. You can have maternal and the fetal complications, which are more common. But whereas in late onset preeclampsia, the onset of proteinuric hypertension is after 34 weeks, and generally the maternal and the fetal complications are less, and then we can deliver the patient once when it is beyond 34 weeks, we do not have much of maternal and fetal complication. Then comes what is the basic pathophysiology. All of us are familiar with this diagram where in non-pregnant status, there is spiral arterioles are like this, but whenever there is normal pregnancy, there is widening of the spiral arterioles and it fails to respond to the increased angiotensin, and it is prevented from vasospasm. But in cases of preeclampsia, whenever there is invasion of the trophoblastic tissue is partial and the widening it fails to occur. So this leads to poor placentation or shallow placentation. Then coming, why there is we know that there is endothelial dysfunction, which is the basic cause for all these complications. In here, we see the anti-angiogenic factors, that is soluble SFLT2 and PIGF increased in PET. So here we have this in normal one, a normal patient, the endothelial health relaxation occurs, but whereas because of this proper attachment of the VEGF to FLIT1 and TGF beta 1 here, normal to all these receptors. But whereas in preeclampsia, there is failure of this SFLT and the VEGF is reduced, and all these things, endothelial dysfunction occurs because of impaired relaxation. Then there are edema, which is very common, which occurs because of so many reasons. Whenever there is a suboptimal uteroplacental perfusion, that is the basic cause. There is increased concentration of leukotrienes and lipooxygenase products. There is decreased fetoplacental production of prostacyclin, which we know that is essential for the vasodilatation. And whenever there is decreased production, there is decreased renal renin secretion, leading to decreased aldosterone secretion, which will cause decreased plasma volume. Then when it is decreased uteroplacental perfusion, or it could be elevated maternal thromboxane prostacyclin ratio. So decreased uteroplacental perfusion, there is increased uterine renin secretion, and again because of elevated maternal thromboxane to prostacyclin ratio, there may be increased angiotensin 2 sensitivity. That is what I said. In response to the increased angiotensin 2 sensitivity, there is failure of vasodilatation to occur, which can lead to increased blood pressure. Vasoconstriction occurs. This will lead to endothelial cell injury, activation of the intravascular coagulation and fibrin deposit. And whenever there is venous constriction, this will lead to peripheral and pulmonary edema can happen. And the systemic manifestations or activation of this intravascular coagulation and fibrin deposition at various organs, like when it is deposited in the kidney, it can lead to proteinuria and decreased GFR. And in the CNS, it can lead to seizures and coma. In the liver, abnormal LFT and right upper quadrant pain can happen. In the blood, it can lead to consumptive coagulopathy. So then the next one is how we are going to evaluate. So we have to evaluate. First thing is differentiate chronic from gestational hypertension versus preeclampsia, preeclampsia mild versus in gestational hypertension itself, it should be mild versus severe one. In preeclampsia, again, it is mild versus severe, and eclampsia versus preeclampsia versus eclampsia. So this is the first difference is gestational hypertension versus chronic hypertension. Usually the gestational hypertension occurs in an young patient versus elderly women in chronic hypertension. Primary gravida, here multigravida, it occurs after 20 weeks. It may be pre-gestational. The weight gain and edema are sudden, and we do not have such an excess weight gain or the edema. It may be gradual, and the systolic blood pressure is usually less than 160, but whereas in chronic hypertension, it may be high, and fundus will show only spasm and edema, but chronic evidence of hypertension like AT venous nipping exudates are seen. Proteinuria is generally absent in gestational hypertension, or it is again, in chronic hypertension, it is absent. But plasma uric acid is elevated in gestational hypertension, and it is normal in chronic, and blood pressure after delivery, it comes back to normal, but whereas it persists in chronic hypertension. Then coming to second difference is gestational versus preeclampsia. Gestational primary is not a strong risk factor. It can happen even to a multi. Here, preeclampsia primary is the risk factor. Recurrence rate is 20 to 47%, and recurrence rate is 5%. Total blood and plasma volume are not so much low, but whereas they are definitely reduced in preeclampsia. Proteinuria is absent, it is present in preeclampsia. Edema is absent, edema is present in preeclampsia. No adverse conditions or complications happening in gestational mild to moderate mild gestational hypertension, but whereas in preeclampsia, depending whether it is a late or a early onset, any maternal and fetal complications can happen. Then comes the third difference is gestational hypertension versus mild and severe. See, in mild, always the systolic pressure is less than 160 and the diastolic pressure is between 90 to 110. In severe, the systolic blood pressure is beyond 160 and the diastolic is beyond 110. There is no moderate hypertension. Then coming to how do you diagnose this pregnancy-induced hypertension or PET, where there is proteinuria is more than 300 milligram per hour of urine, 24-hour urine collection. We no more do it. We just do a simple protein creatine kinase ratio, which is about 0.3 milligram per deciliter, or a dipstick where you find it is more than 2+. In the absence of proteinuria, new onset hypertension with new onset of any of the following, we have to diagnose as preeclampsia. Whenever there is thrombocytopenia or renal insufficiency, when the serum creatine level goes beyond 1.1, impaired liver function test, pulmonary edema, new onset, headache, we have to think about it. Again, the severe features are when the systolic blood pressure is more than 160 and when the diastolic pressure is more than 110. And again, the thrombocytopenia less than 1 lakh, severely impaired liver function test with the elevated liver enzymes and the right upper quadrant pain and renal insufficiency where the creatinine level is beyond 1.1 milligram per deciliter. Pulmonary edema, new onset headache with visual disturbances. They all feature to severe type of preeclampsia. Then the fifth difference is the eclampsia, where there is newer onset of seizures in a woman with preeclampsia preceded by increasingly severe preeclampsia, or it may occur unexpectedly in a patient with even a minimally elevated blood pressure or no proteinuria. So blood pressure is only mildly elevated in 30 to 60% of the women who develop eclampsia. And it can happen in antepartum in 53%, intrapartum in 19%, and postpartum in 28% of the cases. So then the next thing is, how do you diagnose the severe disease early? First thing is, in any pregnancy, it is important to decide whether this patient will develop gestational hypertension or PET, whether it could be early onset or late onset. So we need to calculate certain risk factors: nulliparity, multifetal gestation, preeclampsia and the previous pregnancy, chronic hypertension, pregestational diabetes, gestational diabetes, thrombophilia, SLE, obesity, antiphospholipid antibody syndrome, elderly primary pre-existing renal disease, and assisted reproductive technology is one important factor, because we do get a lot of women getting preeclampsia and diabetes in ART pregnancies. And obstructive sleep apnea is also a marker. So it can vary from all the symptoms: headache, visual disturbances, dyspnea, chest pain, right upper quadrant pain, lower urinary output, and severe edema. Pregnant women with these symptoms should be suspected to have preeclampsia even when there is no proteinuria. The laboratory findings: urine protein, I have already explained; complete blood count, where the platelet count and anemia can be assessed; liver enzymes, serum bilirubin, serum creatinine and uric acid, and serum electrolytes in severe cases it is needed, and a coagulation profile. And whenever the platelet count is less than 1 lakh, you have to again think about the associated HELP syndrome. So uric acid, does it have any predictive value or diagnosis and prognosis? Here, studies have now shown that uric acid may increase very early and has been long associated with preeclampsia, but prognostic value we do not know. See, evidence is accumulating pointing to a role of first trimester uric acid level as a predictor of preeclampsia, though its accuracy may not be optimum. In a subgroup of women who develop hypertension in a course of pregnancy, serum uric acid is a good predictor of preeclampsia with good sensitivity and specificity. Among women with preeclampsia, uric acid levels may identify those who will develop more severe complications, Some evidence from experimental studies seems to point out a pathogenic role for uric acid in the development of preeclampsia. Then again, ultrasonogram. Ultrasonogram, mainly the maternal and the fetal ultrasonogram is necessary. As far as we see the maternal part of it, you have to look for the subcapsular hematoma and hepatomegaly, kidney, signs of evidence of renal causes of hypertension, chronic renal disease, whether there is any change in the corticomedullary differentiation, ascites, pleural effusion, and worsening signs of preeclampsia. And then the fetal thing, we are all very well aware, fetal biometry, amniotic fluid, uterine artery Doppler, and then umbilical Doppler, all those things, evidence of showing that fetal growth restriction, all these things have to be monitored along with the placenta. See, then the next one is, we are now insisting, the government is insisting on getting an echocardiography for all pregnant women as well as ECG. ECG determines the, echo determines the mechanical function, and ECG determines the electrical capacity. So the patients with severe preeclampsia can even go for hypertensive failure, and that might lead to pulmonary edema. Then the fundus examination is essential to differentiate a chronic and a newly onset disease, where we have to look into papilledema, hemorrhages, AV nipping, etc. And additional imaging, I said about echo, is very, very important. And we X-ray chest may not be required except when the patient goes in for ARDS or pulmonary edema or pulmonary embolism. And MRI in general, we do not do it except when we suspect cerebral venous thrombosis or any cerebrovascular accidents, like thrombosis or hemorrhage. Unless these are evident, then we generally do not recommend MRI. So about the uterine artery Doppler, I think we have to start working at 18 to 20 weeks, and it shows it has got a very high negative predictive value rather than a positive predictive value. 70 to 80% of detection rate for late onset preeclampsia and 30 to 40% for early onset preeclampsia. In the recent years, first trimester Doppler performs a better in prediction of early onset preeclampsia than the late onset preeclampsia. Okay, then PAGF test, that is placental growth factor. It is now currently used whether, whether we can predict the gestational hypertension or a gestational hypertension and other hypertensive disorders, and how it is going to predict the outcome upon the fetus and the mother. In an asymptomatic for patients with preeclampsia, PAGF test can be done, and if it is found to be low, it becomes low risk, low likelihood of developing preeclampsia, routine antenatal care. But if there is reduced PAGF, that is placental growth factor is reduced, high likelihood of developing preeclampsia, and that patient needs a close monitoring. Here you see the percentage of, that is the ratio of soluble FMS like tyrosine kinase to PAGF. See, generally the PAGF, this ratio, when it is, you can do it between 20 weeks or 30 weeks, and then what is the chance of that particular person getting preeclampsia, it can be predicted. Like if it is less than 38, less than 20 weeks, or beyond less than 38 weeks, beyond 34, or if the patient is likely to develop preeclampsia within 4 weeks, if it is greater than 38 or less than 110, or if the patient has got highly suggestive of preeclampsia, if the ratio is more than 110, and if it happens at a lesser gestational age, then the early onset of preeclampsia is going to be more. So now coming to mini-PS, this mini-PS, it is nothing but it is a risk score that is commonly used by the healthcare workers, where they can various variables are used, like maternal weight, symptoms, systolic blood pressure, and dipstick proteinuria. These are available to them, and the GenPR is according to that. You are added to that. They use the platelet count and the serum creatinine, and full PS is it is independent predictor of adverse maternal outcome. The gestational age, chest pain, dyspnea, SpO2, platelet count, serum creatinine, and liver function test are all added to that. So you may ask why it is significant and what is it? It is a model to improve the preeclampsia management, and it helps the healthcare workers in making decision whether the patient needs further. So first thing is the mini-PR, where they have done, as I have said earlier, they do only the maternal weight, symptoms, systolic BP, and dipstick proteinuria. And there are, apart from that, there are so many other variables like parity, gestational age, dipstick thing, headache, SpO2 is very commonly done because of the availability of pulse oximeter. And they can ask the patient whether they have blurry vision or abdominal pain, and then chest pain and vaginal bleeding without labor and shortness of breath. All these things, variables can be marked, and they have tried this CLIP trial implementation in so many, more than 32,000 pregnancies in low resource countries like Nigeria, Mozambique, Pakistan, and including India. And they found out that it has got an accuracy of 85%. And if the mini-PS is positive, then these patients should be referred to a particular higher center where they can be followed up so that they can reduce the maternal morbidity, mortality, as well as the fetal. So then the adverse effects in CNS, headache, visual symptoms, and then severe complications, you can get the eclampsia, press, cortical blindness, stroke, TIA, RIN, and in cardiorespiratory things, it can have chest pain, dyspnea, and then in uncontrolled severe hypertension, maybe when the oxygen saturation is less than 10, 90, or pulmonary edema is present, or whenever there is myocardial ischemia or infarct, they have to be attended as an hypertensive emergency crisis. Again, all these hematological factors, there may be elevated WBC or APTT may be prolonged with a low platelet, elevated serum creatinine and uric acids, and then evidence of acute renal injury. These patients, they need dialysis, and likewise, if the platelet count is low, maybe we have to take an imminent action, transfuse the blood product. And then if there is evidence of hepatic dysfunction, and when there is prolongation of INR or hepatic hematoma or the rupture, it has to be viewed as an acute crisis, and fetoplacental thing can be measured by the non-reassuring fetal heart, IUGR, oligohydramnias, or absence of end-diastolic flow, or even reversal. And this, whenever there is a fetal compromise, it can lead to, if it is not handled immediately, stillbirth can happen. And health syndrome, I think everybody knows it happens in 20% of the pregnancies complicated by severe preeclampsia. The clinical presentation is 12 to 18% are normotensive, and 13% they do not have proteinuria. At diagnosis, 30% of the women are in the postpartum, 18% are in term, and 52% are preterm. And the mortality is going to be high when it is not handled properly. We know the components, that is hemolysis, elevated liver enzymes, low platelet count, and it is again classified to 1, 2, and 3 based upon the platelet. Okay, then the biomarker testing is by placenta. We can find the soluble FLT in the, again, placental growth factor. Then in the, this one in the WBC, you can have the neutrophil gelatinase associated lipocation, that is the NGAL. In the heart, brain natriuretic polypeptide and relaxin that is being a biomarker for finding out the vasoconstriction happening. Then the next one is, how do you manage? The basic management is we need to save the mother and the baby and reduce the morbidity and mortality, as well as we need to have save ourselves also. So what should not use? Do not use nitric oxide donors, progestin, diuretic, and LMWH, except in cases of Apla syndrome, and not to recommend magnesium, antioxidants, and no restriction of dietary salt. You need not give the patient extra salt, and advise them not to. Some advice regarding rest and exercise, moderate exercise and workup can be done. And antiplatelet factors like 150 milligram of aspirin can be started from 12 weeks. It should be started only at the night. And the high-risk patients and moderate-risk patients, these are all the patients who need this low-dose aspirin. And Gestosis score is an excellent one. Whenever you find more than 3 score, then these patients, they need the start of this low-dose aspirin. And how do you manage the patients with chronic hypertension? Pre-evaluation. Prior to pregnancy, they have to be evaluated. Try to change them from this telmisartan and other ACE and ARB inhibitors, and then it should be made to a safe thing. And when the hypertension is under control, they can be planned for pregnancy, and you should try to maintain the target level at the 130 to 85, and beyond 140, 90, you get alert. And the common drugs used are labetalol and nifedipine, and methyl we no more use. Add aspirin to these patients and offer PAGF testing to find out whether the patient is likely to go in for PET or not. So you have an additional, every week the patient has to be seen in a poorly controlled hypertension. In a well-controlled one, maybe the patient needs to come once in 15 days, and delivery is planned before 37 weeks. It's planned if they have associated complication. Otherwise, they can be planned for delivery after 37 weeks. And if early birth is needed, offer steroids and magnesium sulfate for neuroprotection. Postpartum follow-up is continue the drug and stop the drug for when it comes to 130/80, and restart if it again goes back to the pre-gestational level. And predict preeclampsia early is by full pairs and the preps, yes, which can be used. Full pairs can be used at any time. That is not the initial one, but the prep pairs can be used only up to 34 weeks. Both models, they do not predict the outcome of babies, but gestational score is one ideal thing. Then how do you manage? Again, assessment of all the basic biochemical parameters and the platelet count, and that will give us an idea. And ultrasound, fundus examination for both, they can predict how the outcome is going to be. And in the cases of hypertensive emergency, it is always the patient should be admitted in the critical care unit, given IV labetalol or nifedipine orally or hydralazine. And once when the BP falls to 140/90, then you have all the other investigations and done, and see whether we have to deliver the baby or not. And in severe conditions, we can use IV nicardipine, nitroglycerin, and nitroprusside also. And these are all the drugs which we commonly use practically. I skip that. And other in severe condition where there is eclampsia, it can be IV magnesium sulfate. Either we can follow the Pritchard's regime, or you can follow the Magpie's regime. IV regime, either thing can be given. But once when you are started giving magnesium sulfate, and when we want to prevent eclampsia, it is always safer to deliver the patient, and the child and the mother should be given steroids and magnesium sulfate for neuroprotection. What we give for the mother is quite sufficient for that of the neuroprotection for the baby. When we are doing a magnesium sulfate, we have to follow the respiratory rate, patellar reflexes, and urine output has to be managed. So the delivery, when do you deliver the patient? For controlled hypertensive or controlled preeclampsia, it can be go up to 37 weeks, but we should deliver it earlier if there is any evidence of maternal complication, either as persistent headache or if persistent elevated blood pressure not settling with the multi-drugs and visual drug disturbances, and then when there is any cardiac problem or HELP syndrome and worsening renal function, pulmonary edema, or eclampsia, or whenever there is evidence of placental abruption. So the delivery can be in mild preeclampsia, it can be delivered at 37 weeks. In severe preeclampsia at 34 weeks. In eclampsia, it should be delivered as early as possible once when the mother is stabilized. Postpartum, you have to continue measuring the blood pressure, and when it is less than 130/80, we can start, but you can continue when the level is beyond 150 to 100. Then there are certain future things where there are a lot of newer things like repurposed drugs like proton pump inhibitors, sulfasalazine, metformin, which can be which can be used in future as a therapeutic intervention. But the advantage is that some drug safety is being known, but if there are limitations, is probably we do not know the safety, and we need to have a larger future trials. Plasmapheresis is one thing where it can remove the soluble FLIT transiently, and this can remove this, and by removing this, there is a possibility it can be reversed. The disadvantage is it's quite expensive and invasive. Monoclonal antibodies are highly specific and can be engineered. And advantages, it's again the cost. Disadvantages, it's expensive, still needs more safety data. And gene silencing, genetic remodeling, bioengineering, it is again going to be a newer venture where it can target the siRNAs and FLTs. So to conclude, I should say the overall risk, you don't think that once when you treat the hypertensive disorders, the patient is going to get completely cured. More than that, 1 in 5 patients has got the overall risk of developing recurrence of this hypertensive disorder in the future pregnancy, be it a preeclampsia or a the gestational hypertension. And the most important thing is we have to see that these patients are at a high risk of developing coronary artery disease and persistence of hypertensive problem, and then cerebrovascular disease and stroke and heart failure. And the mortality, you see this, the initial 10 years, they may develop hypertension and coronary artery disease, but beyond greater than 10 years, they are at very high risk of developing all these things. And hence, it is our duty as a consultant, and we should have some community health system where these people can be called back. This preeclamptic woman and hypertensive disorders of women can be called back after 5 years to follow them up every year, and they should be undergoing cardiac evaluation either in a primary setup with the help of a physician or with a cardiologist. So my last slide will be preeclampsia. The basic pathology is the placenta, and the placenta, there is defective spiral arteriole remodeling, says that it leads to systemic vasoconstriction and endothelial dysfunction. And again, there are pro-inflammatory changes that affects the brain, also causing convulsion. In the kidney, it causes proteinuria, maybe in untreated and in recurrent lesions or underlying basic renal disease causing hypertension. They can go for end-stage renal disease. And in the liver, it causes hemolysis, elevated liver enzymes, low platelets, and there may be sometimes rupture and hematoma in the liver. So I thank profoundly Kanchan Sharma for having called me for this talk. And the right time for the baby and mother, we have to identify, save the mother and save the baby, and give priority to the maternal mortality and morbidity. Thanks for the opportunity.
Madam, I am always obliged by your wonderful talk. Always, I wish to hear more and more. I always learn from you that willingness to give a lot of time and energy to something because it is important, and the determination, dedication, and self-discipline, all I have learned from you, madam. Now over to chairpersons for summing up the talk.
As usual, excellent talk, Madam, Ramani Madam. And you have touched all the points, basic from pathophysiology to prediction, and also.
You are muted.
Okay. You have covered everything in half an hour time. It takes 1 day or 2 days to talk about hypertension, but you have covered everything within half an hour. Excellent lecture, ma'am. Thank you, ma'am.
Excellent presentation. Ramani madam, it was really wonderful. We learned many new things. Every time you speak, some new things come and we learn it. So really, thank you, madam. Thank you, madam.
Ramani madam, thank you very much for highlighting the role of FLIT and PLGF in the 3rd trimester, because that is the latest as a screening measure for preeclampsia, which we have, as per the ISIO guidelines, which was released about 2 months ago. So I think if you feel that the patient is at risk of preeclampsia, it's always better to do the ratio, and based on the ratio, you can categorize as low risk or high risk.
So that is the chart what I have put up. That was the recent one. So based upon the gestational age and the ratio, we can predict whether the patient is likely to go in for complications or not.
Thank you. The other chairperson?
Yes, ma'am. Ma'am, excellent presentation, ma'am. Yeah, Dr. Revati madam is saying something.
There's one point I would like to add, apart from this risk factor, echocardiogram in the mid-time should also show some changes, which that is based on that you classify them as low risk and high risk, which gives us an idea about the probable complications in these patients and the intensive management that has to be given to those patients.
Madam, here I would like to add up, it is always safer to do the echocardiography in the first visit. The reason is, and if needed, it can be repeated in the late stage. Reason is 2 things. We can pick up whether the patient has got chronic hypertension or not. Just by the mere left ventricular muscle mass index, calculating that, it will pick up whether it is a chronic hypertension. Then the next point is, if the patient has got some undiagnosed cardiac valvular disease or any cardiac disease that is incompatible, the pregnancy cannot be there in the first trimester. If we are doing it excellently, we can manage the patient. And if you need termination also, without any complication, you can terminate. So I feel it is better to shift from mid-trimester to early trimester doing an echocardiography.
The thing is that the easily available test which we have to do during pregnancy, which helps a lot in the management part.
My thesis was single left ventricular muscle mass index. I calculated at any trimester was a single index to differentiate chronic hypertension from preeclampsia. So we know that chronic hypertension, not much of complications if it is well controlled, but preeclampsia, it can have any adverse effects upon the mother and the fetus at any time.
Thank you, madam. There is a question by Dr. Radha Lakshmi in the chat box. Madam, can you ask yourself? What is the cutoff value of first?
Uric acid in the first trimester, madam, to predict.
That is only an upcoming thing. Uric acid normal thing is we say 4 to 7 milligram per day. Okay, if it is on the higher side, or even if it is going to be more than 7, then we have to think about, you monitor the patients very closely. One more thing is uric acid may not be an indicator only for this, because some of the other collagen vascular diseases and all these other diseases can also show higher increase in the uric acid. So you combine everything, combine the risk factors, uric acid and the ECG, echo, everything put together can give us an idea. Otherwise, they say that uric acid has got no predictive value.
Thank you, madam.
Thank you.
Thank you, madam, for your wonderful talk, and we are obliged by your blessings. Now coming on the fourth talk, for which I'll invite Dr. Kavita Barnwal to conduct the session, because I am the speaker in that very talk. Dr. Kavita Barnwal is a senior consultant laparoscopic surgeon of the Samarpan Hospital, and she is the associate professor of Lord Buddha Koshi Medical College, and she got so many awards. At present, we know her because she is there as a candidate for Urogynec committee, and wish her all the best for her future endeavor. Madam, the mic is yours to introduce the chairperson. And for
Thank you, madam. Thank you, Kanchan madam, for your nice words and for your blessings. So really, we all need blessings. We all are hardworking, dedicated persons. So I think we should be given a chance to serve this organization, Foxy. So with these words, thank you, Kanchan madam, for giving me the opportunity. Today, this fourth session will be done by Kanchan madam. She will be speaking on healthy nutrition and non-communicable diseases.
On the pro-fertility diet. I am speaking on the pro-fertility diet.
Okay. So actually, yeah, Kanchan madam doesn't need any introduction, but still we have 3 chairpersons. So I have to introduce them. Malati Prasad madam. She is a director, Trichy Fetal Medicine and Fertility Center, and she has got affiliations with ATN RCOG, Foxy IMA, RCOG, ISUAG. She has conducted fetal medicine workshop in South India, invited faculty in ASUG as well as Foxy. She has won the first prize for paper on fetoscopic skin biopsy in epidermolysis bullosa in National Conference Induction 2011. Best paper prize at Foxy for alpha thalassemia and non-human hair drops, and she has got many publications, and she has held many posts like Secretary, Trichy Obsgani Society, Executive Member of Imaging and Fetal Medicine Committee, Foxy between 1922, Vice President, Trichy Obsgani Society, past Secretary, IMA in Trichy Society. So, Madam, I really invite you to chair the session of Kanchan Sharma, Madam. Next chairperson is Dr. Lakshmi Prabha madam. She is consultant of Obsgani Rana Hospital and Maruti Hospital, Tiruchirappalli. She has passed from Madras Medical College and done DNB from Christian Mission Hospital, Tiruchirappalli. She has won C. Subramanian Award for Best Outgoing Student in Clinical Surgery in 1997. Had been Executive Committee of TRIOS for many years. She is now Secretary of TRIOS between 2022-24 and had been in editorial committee tracks author articles for Track Journal, have been in organizing team in national conferences like the KOGS, Dakshin, and Medicon. EC member of TNFG, been in organizing committee, Yuva Foxy Trichi, has participated as a speaker and chairperson in many state as well as in national conferences, and her field of interest is high risk obstetrics. So I welcome you, madam, for chairing this session. And third chairperson is Dr. Sujata Alagasan, madam. She is professor in Obs and Gynae, Tirunelveli Medical College and Hospital, Tirunelveli, Foxy Tirunelveli branch secretary for 5 years, conducted live Obs Gynae workshop, presented 5 national papers, and best paper award in Yuva Foxy has been received by her. And she was national faculty in ASOG twice. So with these words, I request any of the chairperson who is present here to introduce Kanchan Sharma madam. She actually very humble, very dynamic and academic lady, and she is from Kanpur, but she needs to be upgraded in Foxy as a chairperson, and she's presently fighting for NCD committee. So I think we all need your blessings, and Kanchan Sharma especially in this blessing, because she has organized this whole program. So with these words, I request any of the chairperson who is present here, please introduce Kanchan madam and as well as the top.
Lakshmi, you want to do? Lakshmi? Lakshmi?
Yes, madam, you do.
Yeah. Good evening. My pleasure to introduce Dr. Kanchan Sharma. You want to do Lakshmi?
Yeah, I'm okay to do it.
Yeah.
Okay, good evening all. It's indeed a very, very interesting program. We had a very interesting talks. Thanks, Dr. Kanchan Sharma, for the initiative. You really did a wonderful job. Best wishes for you for your NCD committee chairperson elections. I'm sure you're going to come out in flying colors. We all know Kanchan Sharma. She's the secretary of Kanpur Obstetric and Gynec Society for the year 21 to 23. She's the president of IHRF Kanpur. She's an ART specialist, laparoscopist, colposcopist. She has various trainings in ART and laparoscopy and ultrasound and fetal medicine from AIMS, Delhi. She has got her Foxy Achiever Award, Pratyeka Social Impact Award, Empowered Women Award, many awards. She has done lots of academic events. She's organized many national and international conferences. She's been the chairperson of ultrasound workshop of UPCOG, and she's a member of Foxy IAG and life member of Foxy IAG, IFS, IMA, and many societies. We welcome you, madam, to share your slides.
Thank you, madam, for your nice words. I just want to share the slide. Yes. My slides are visible?
Yes, ma'am.
Yes, first slide is there.
Madam, it's your first slide, your introduction slide, and it's not.
Yeah, and I am audible.
I'm just change the slide, madam.
Yeah, no, it's the program. The program slide.
This is the program slide.
Yeah.
I am thankful to all the persons who are joined today's webinar as a chief guest of honor, and the speaker, and all the wonderful chairpersons. My topic for today is the Fertility Pro diet, because the diet that affects each and everything, even the fertility, because the diet may be fertility pro, it may be oxidant free and the antioxidant rich. That is a very good diet that we should adopt and advise to our patients also. Usually we see, as we are there in our OPD, we see that the patients do come to us, and many times they come back and ask, madam, we have not asked anything about the diet. Please tell us what to take and what not to take. So Hindi maybe we used to say jaisa ann vaisa man. So kitchens are hard environment, and they form incredibly strong character. That is said by the Jordan. Our food should be our medicine, and our medicine should be our food, as told by Hippocrates. So in Sanskrit, our Gita says that युक्त आहार विहारस्य युक्त चेष्टस्य कर्मसु युक्त स्वप्ना बोधस्य योगो bhavati dukha. The person who is taking right diet doesn't have any problem. So nature is a song of the praise that never stops singing. Many of our books and many of our Sattvic teachers, even Sadhguru and all, they have taught about what type of diet should be there and what actually we should take our diet in our diet. Do we all follow these rules about the diet, or we forget whenever we start taking in parties and etc. Rather, what should we take and what should not we take? Identifying modifiable lifestyle factors such as diet that influence the human fertility is of the major clinical and the public health significance. So evidence suggests that nutrition can play an important role in altering even the fertility related outcome, both even in the men as well as in the female. So there are so many dietary risks and dietary factors which affect even our day-to-day, even lifestyle, even our behavior and fertility that comes later on, that is being affected. Diet and female fertility. First, I will come on this very topic. As we know, carbohydrate, these all the diet, the pictures which I have shown, these rasgullas and jalebis, etc. How tempting these all the preparations are there. But these are high dietary glycemic load things. They are related with elevated fasting glucose level, hyperinsulinemia, and insulin resistance. So they are responsible for high release of free IGF-1 and the androgens. Ultimately, they result in endocrine disturbances and oocyte maturation defect. This is very important point. Reduction in dietary carbohydrate should be there amongst the PCOS women. That usually improves insulin sensitivity in these ladies. So there are a lot many work regarding this. This is a better sugar content of the common fruits, which we can see here. I have mentioned the different fruits. The sugar from these fruits, that is the natural content, is a better one. If we talk of the protein intake on the reproduction is a complex and still unclear how the source or the amount of protein consumption may affect the ovulation function or the woman's fertility. It is well known that the protein intake has been associated with deregulation of the steroidogenesis in the woman affected by PCOS. So it is likely by reducing the hyperinsulinemia. So protein intake should be suggested. The next coming on the fatty acid. What type of fatty acid should be taken, what we advise to our patient and what not. The fatty acid commonly classified as saturated fatty acid, monounsaturated, that is MUFA, and the polyunsaturated, that is the PUFA. Fatty acids are used as the energy substrate during the oocyte maturation and early embryo development, and they serve as a critical precursor for a variety of substrates. So there are so many studies regarding the fatty acid that I'll just mention. First, I'll come on the trans fatty acid. We always see whenever we take a thing from outside, ideally, I have seen many young persons, they are just looking into the outer cover of the box, that how much of the trans fat is there. So this is very important. The trans fat is associated with high risk of ovulatory infertility and laparoscopically confirmed endometriosis. So trans fat should be avoided. It is associated with reduced fecundability within a larger North American preconception cohort. So trans food which are rich in trans fats are the French fries. Do you like it? Cheeseburger and chicken nugget and donuts. These all are rich in trans fatty acid. Now coming on the vitamin D. We all are aware whenever a patient of infertility and many other problems, they are coming to us, we are very much now concerned because of the vitamin D. First of all, because now there are more and more indoor sittings, less of exposure to sun, and vitamin D as such affects many functions of our body. So we all are concerned with the vitamin D level. Vitamin D is an important nutrient which is involved in many fundamental health outcomes, and its role is also there in the ART. It's capable of influencing oocyte quality, preparation of the endometrium for the embryonic implantation. It is said that even endometriosis is associated with higher vitamin D reserve. And vitamin D supplementation could be useful for the management of the endometriosis and reducing even dysmenorrhea. Now coming, the normal range of 30 to 150 nanogram per ml of the vitamin D shows better clinical results with a positive pregnancy test rate and the clinical pregnancy. So vitamin D level should be kept in mind while advising the patient for the fertility pro diet. The folic acid, again, the other nutrient that is very important because the synthesis of DNA is crucial in gametogenesis and fertilization and the pregnancy. So 3 prospective cohort study, which in general suggested a protective effect were there. They showed that folic acid is very important for pregnancy. So initially, in first 3 months, we usually advise our patient for the folic acid, and for those patients who are planning for the pregnancy, because it is said that the folic acid 16% higher probability of the pregnancy is there, and live birth rate even is increased. If there is low serum folate level, there is a poor ovarian response, few retrieved oocyte, and low granulosa cell E2 production. These are the pictures of food which is rich in high folic acid. I have very well shown in this diagram. Coming on another nutrient, micronutrient, that is iodine. Biological mechanism by which iodine deficiency can interfere with the fertility is insufficient iodine that causes hypothyroidism, and there is evidence for a number of mechanisms by which hypothyroidism could cause infertility that we all understand. So thyrotropin releasing hormone elevation that stimulate prolactin, which in turn interfere with GnRH pulsatility. And there is also alteration in androgen and the estrogen concentration in these very patients. So there is a lot many studies on this. It shows that moderate to severe iodine deficiency is associated with a 46% decrease in fecundability. Now talking of the oxidative stress, this is very important. There are many of the diet products which causes reactive oxygen species production in our body, like high sugar, etc. I'll come on that point. And antioxidants are contained in balanced level that should be there in our body to fight with this. There are antioxidants which have a protective effect. Primary antioxidants are naturally produced by our body. Other are the secondary antioxidants which we only get from our food. So oxidative stress is associated with age-related decline in fertility, decline in ovarian function, and decreased steroidogenesis. ROS negatively affects oocyte maturation. We all know, we all are discussing about the oxidative stress. There's a decreased oocyte penetration of the sperm and decreased fertilization and the blastocyst formation. And even decreased implantation is there, and increased loss of implanted embryo is there with this. So antioxidants along with iron and magnesium, they should be supplemented. And if we talk of the zinc is an essential cofactor for the several metabolic reactions. because if there is a zinc deficiency, it impairs the synthesis and secretion of FSH, even LH, and cause abnormal ovarian development. So usually now you are seeing that many of the brands which are coming in the market is supplemented with the zinc and vitamin C. It is the most important antioxidant in extracellular fluid that we get from usually many persons have a habit of taking this citrus fruits like Nibu, etc. with the diet. That is good source of vitamin C, and even amla. That is a very good source of vitamin C and antioxidant also. It helps recycle oxidized vitamin E and glutathione. Vitamin E, if we talk up, because in many cases we are adding vitamin E while treating for the infertility and even in the early pregnancy. It is the strongest antioxidant which is present. It is a free radical scavenger, protects the DNA in the cell from the damage. Now, beta carotene. This is a provitamin. We are advising to our patients more of the whole fruit, more of the pomegranate, more of the carrot, which is rich in the carotenoid. All these fruits which I have shown in the figure, they are rich in the beta carotene, and they are advised for this very effect. And N-acetylcysteine, which is a powerful antioxidant, it is to be obtained by all these products: spinach, apple, even avocado, broccoli, tomatoes, and carrots, and the pears, oranges, garlic. Reduced glutathione at the cellular level and acts directly on the reactive oxidant radicals. It has its antioxidant effect and experts protective effect to the cell. We have an additional benefit of NAC, that is, it improves insulin sensitivity and preserves vascular integrity by the vasodilator effects. It has an anti-androgenic effect. So it is also an oxidant and mucolytic agent. It detoxifies harmful substances in the body. Antioxidant, this is antioxidant, and promotes sperm motility and survival in the female genital tract. If we talk of arginine, this is a very important semi-essential amino acid. We are usually now prescribing to our patient L-arginine preparation. Even in many cases of infertility, while we are giving the treatment for infertility, because this is a rich source of nitric acid, and it is very useful for the thin endometrium and high radial artery resistance index. It is said that where there is a thin endometrium, because it increases the blood flow and endometrial receptivity. So usually we advise its natural source is wheat, oatmeal, and a peanut. This is very well shown in the diagram. Nuts, even coconut, walnut, almonds, and soybean are a good source of L-arginine. If we talk of the vitamin B12 and B6, usually nowadays there is a much of noise about the B12 deficiency. So what are the foods which have highest level of vitamin B12? These I have shown in the diagram: broccoli, avocado, and all these foods, they have high vitamin B12. Supplementation helps to reduce the oxidative stress and improves ovulation, thus improves reproductive health also. So antioxidants in combination, they have a very good effect on fertility. So my suggestion is eat healthy and stay healthy. These are some of the products which keep you healthy. Broccoli, which is a rich source of vitamin A, C, E, fiber. Vitamin E is in a sufficient amount in almonds, haldi, turmeric is a very good. So dietary pattern, there are so many studies, nurses health study and other sun study that has been done. There's a Mediterranean diet, which is suggested in many cases. And because several studies shows that different diets in preconception may impact IVF outcome even. And MED diet score was positively related to clinical pregnancy and live birth, in particular in the women of less than 35 years old. So, few slides about the diet and the male infertility. It is said that even the males who are coming to us are very much affected because of content like inositol, copper, calcium, zinc, and magnesium, fructose. They all affect, even carnitine, because we are supplementing, affect the sperm quality. So insufficient supply of these in the diet may be very crucial and affects the spermatogenesis, sperm quality. So research study indicate that healthy dietary models clearly correlate with the better sperm quality, and especially with the reduced sperm DNA fragmentation, patients should have a better diet, which is filled with all these content. So, recommended dietary standards: diet rich in raw vegetable and the fruit and the whole grain, and especially fiber-rich products, they are recommended. Olive oil, oily sea fish from a reliable source, nuts, yes, seeds, and stones, avocado, and the good source of protein, especially lean poultry and the low-fat dairy products, legume, fish, and seafood. Yes. The trace elements. There are so many trace elements which affect the semen quality. So oxidative stress is also very important regarding the semen quality. ROS have been shown to alter the motility, morphology, and the sperm DNA stability. As we are usually discussing and seeing the oxidative stress on the morphology of the sperm. This is a very good indicator of the sperm quality. We usually are adding leukocarotene in the male infertility. That is, leukocarotene plays a role in the sperm metabolism by providing readily available energy for the use by spermatozoa, which positively affects the sperm motility and the maturity. Leukocarotene in the male infertility is very important. It is a small protein that binds to help the transport fatty acid into the mitochondria, the site of energy production within the cell. You can see in this diagram that oxidative stress and this leukocarotene affects each and every step of the sperm morphology, development, and quality. So there are so many studies regarding L-carnitine in the male infertility. You have seen in many medicine preparations where these are added. Coenzyme Q, myonistal, vitamin C, vitamin E, lycopene, selenium, zinc. All these are usually added in the preparations which we are giving to improve the sperm motility. We also get from many dietary supplements. So diet which is negatively affecting fertility, and I can say that high intake of red and processed meat that negatively affect the fertility. High intake of sweet drinks and snacks should not be advised to the patient. Low intake of fiber, vitamin, and minerals, they badly affects fertility of the patient. Poor consumption of fish, poor consumption of vegetable and fruits is bad. Intake of trans and omega-6 fatty acid is again bad. High energy density diet and poor consumption of nuts and seeds should not be taken. And what is the fertility pro diet? should always avoid trans fat, use more unsaturated vegetable oils like olive oil or canola oil are we using in our diet. Eat more vegetables, protein like beans and nuts. Choose good carbohydrates like oatmeal, beans and veggies. Avoid pasta, avoid rice, avoid candy. We have different type of diet in our different type of parts of the country. Drink whole milk or have ice cream or the full fat yogurt. Take multivitamin that contains folic acid and other vitamin B. Boost iron intake with fruits and the bean, but not the red meat. Say yes to water and no to soft drink. This is very important. Aim for body weight within the 7.5%. Fertility one zone, 7.5%. Exercise daily, but don't overdo it. So what are the prohibited diet? This is again a prohibited diet containing trans foods. These cold drinks is again a prohibited diet that should not be taken. And this is the suggested pro-fertility diet that is always suggested and needed. Thank you very much. I'm obliged for giving me chance and hearing
Thank
me.
you, Kanchan Madam, for your nice presentation. So I request Chairperson Malati Prasad Madam, if she is here, President Trichy Organic Society, please conclude her talk, though she has presented well.
Thank you, Dr. Kanchan Sharma. I think it was a wonderful talk. You touched on many aspects of nutrition, diet, and even supplementation and infertility. I think it was, I know, and you also highlighted about the fact of trans fatty acid, the diets which contain trans fatty acid. So very enlightening talk. Thank you very much, Dr. Kanchan. Do you have any questions in the chat box, please? Any questions in the chat box?
No, it's comment only.
Okay.
Good comments.
Thank you. Thank you, Dr. Kanchan, for the opportunity. Thank you.
Thank
Madam,
you, Chairperson,
Madam, Lakshmi
for
Kumar
your
Madam.
wonderful comments.
Yeah, thank you, madam. It was actually in short, you had covered everything. You had actually enlightened us to eat good food, and you had told us like please avoid for fast foods and eat cooked foods and lots of greens and vegetables with lots of all the hidden the nutrients in many foods was clearly explained. Thank you so much. It was wonderful talk. Best wishes for your chair elections, madam.
Thank you very much. I am obliged.
Sujata Madam, are you there? Sujata Madam? I think she's
Hi,
not
Dr. Chinmay.
Okay. So thank you.
I see here two wonderful persons. Dr. Charmila Madam is there and Dr. Chinmay Madam is there for the next talk. Dr. Aruna is there as an expert. Welcome, Dr. Chinmay Madam, Dr. Charmila Madam, and all the wonderful panelists. The next is the thyroid disease and pregnancy. A wonderful, wonderful panel going to be happen because our moderator, Dr. Charmila Madam, has prepared everything very, very well. Madam, you are the Vice President-elect Foxy 2024. My sincere thanks for joining this. You are the Chairperson Clinical Research Committee in 2016 to 18, ICOG Governing Council member, 21 to 23, National Coordinator, UNICEF Foxy, PCA, and MEDA Foxy PG Program, ISAR Gurukul Program, 22 to 23, Series Convener of ICOG General Club and ICOG Certificate Courses, WHO Southeast Asia Region MDSR India member, past Secretary Trichy Society, President Menstrual Hygiene Management Consortium, and Joint Secretary Justice India Association. Madam, most welcome and thanks for joining.
Thank you, Kanchan.
The experts are Dr. Aruna Suman, and she is the professor, HOD, and Vice Principal, Government Medical College, Telangana. She was the Joint Secretary. Who doesn't know Dr. Aruna Madam? She was a very loving and good person, and she
Kanchan,
was
thank
a
you so
trainer
much.
of. And first of all, we wish you. She is at present for the committee
Endocrinology.
chairperson of the endocrinology committee, and we wish her all the best of luck for her future endeavor. You are most welcome as an
Thank you so
expert.
much.
Dr. Chenmai Ratha madam, you are most welcome. You are joined this because of my
It's okay,
request.
Dr. Kanchan,
We
they're
are
all
obliged.
seniors
You
there,
are
we
just
all
2
know.
words. You are the director and the lead consultant fetal medicine, Resolution Fetal Care Center and the Research Institute. You are the senior consultant. You are the chairperson at present of the National Perinatology Committee, FOXY, and president of the Society of the Fetal Medicine. You won so many awards and had so many publications. You are most welcome, madam.
Thank you so much, Dr. Kanchan.
The panelists are wonderful panelists are Dr. Jairani, you are there. Madam, you are there, Dr. Jairani.
Yeah, Kanchan, I'm there, Kanchan. I'm
You
here.
are the senior
Yes,
consultant of reproductive medicine, director Akash Fertility Center. You are president of OGSSI at present. You are most welcome. You got so many medals and awards and publication. The most important thing is about you that you are at present the candidate for chairperson of the sexual medicine committee, and our all the best wishes to you. You come with the flying colors.
Thank you, Kanchan.
The other panelist is Dr. Gothai, madam. Madam, you are there? She's there? She's there? I think she has not joined. She is the president of FOXY.
Thoothukudi is a very important place here. The Port Society. Yeah.
Place. Yeah. She has collected many awards for FP achievement and special interest in Tamil, Vice President of Thoothukudi IMA. And she got the Best Woman Award. Madam, you are welcome. She is there or not? I don't know. The next Dr. Jasmine Rajesh Tilak. Madam, you are there? Dr. Jasmine, madam? She's again, I think, is not there. She is at present secretary of Thoothukudi FOXY. I welcome you, madam. Dr. Uma Maheshwari. Madam, you are there? Dr. Uma Maheshwari, madam, you are there? You have joined the government job in 1998 and was the HIV department in charge in Rajapalyam, GS for 8 years. Madam, you got many awards. You are most welcome over here. The next panelist, Dr. G.R. Radhalakshmi. Madam, you are there. I can see you. Yes, most welcome. You have done MBBS from Thiruvalley Medical College. You are DGO from Kapil Park Medical College. Embryology courses you have done even. You have done ART clinical course, and you are at present the director of Prasanna IVF Center. Madam, I welcome you in this.
Thank you, madam. Thank you, madam.
Kalpana is not joining.
Dr.
She's gone for a cesarean.
Kalpana is not there.
No, she's gone for a cesarean.
Cesarean. Okay, okay. Dr. Kalpana is a chairperson for the chairperson in fertility committee, and she is at present has a very good candidature. She was the national coordinator of infertility committee FOXY and secretary MOGS, and her academic profile is very good. She has gained many awards and medal and many publications. Next, Dr. Swati, madam, you are there? Dr. Swati Rathore.
I think Swati and Manisha have not joined.
Achha.
Mary and
Dr.
Madam also I'm
Mary.
not seeing.
Dr. Mary, madam, you are there?
Maybe Sahiti can just call once and check in case.
Saiti, please call them. She's a president of Nagar Koli. So how
Nagarkoil.
many panelists are there? There
I
are
see
two-
Dr. Jayarani, Dr. Uma Magesh, no, Dr. Radha Lakshmi, and the experts.
Dr.
Right.
Lakshmi Prabha is also there.
Madam, you change your.
No, Lakshmi is not a panelist. She's a chairperson.
Okay.
You change your name, doctor is written.
Yeah, two of them are put as doctors. I think it is one. She's joined
And
through
it's
two
the
devices.
same, it's her madam only has joined.
Madam, you have
from
to name yourself. What's your name, ma'am?
You can exit from.
Ma'am?
Dr. Uma, you just,
Maheshwari. Okay,
Uma,
fine.
click on the left side, Uma, right side, Uma, and rename yourself, Uma.
So there are three of.
I have changed, ma'am.
So there are three.
Yeah,
Madam,
Sahiti, you
log
can
out
change
from
for
one
madam.
device.
Dr. Uma Maheshwari just that. Yeah.
So there are three
Now the
panelists and
mic
two
is to
experts.
Dr. Charmila, madam.
Yeah.
For,
So there are three panelists and two experts. I think everybody is exhausted after listening to NCDs from 4 o'clock. Everybody would like a
But the
cup of
fact
tea, I
is, ma'am,
think.
we can't forget them. They're all the time there, one after the other.
So we'll make it very practical.
Charmila, make it quick and fast. I too have a
I can finish it in
IVF,
10 minutes.
everything
I can
waiting.
finish it in 10 minutes also if you want, but Kanchan may not agree, right?
Everybody knows Kanchan now. Kanchan is well popular now.
So we'll make it very short.
Whatever you think, yeah.
So make it very short. So welcome to all the experts, Dr. Aruna Suman and Dr. Chinmayi Ratha, and the esteemed group of panelists, Dr. Jayarani Kamaraj, Dr. Uma Mageshwari, Dr. Radha Lakshmi, and three of you are there and two experts are there. So we'll have it very short and sweet, and suppose somebody wants to talk on thyroid disorders, we'll give you a separate webinar for that. You can talk there. But today you'll give only your opinions of how you're managing it clinically. We do not want lots of theory there because already 4 talks full of practical points with theory was talked about. So we'll make it very, very brief. So can I ask Chinmayi, do you think the universal screening should be recommended for all pregnant women for thyroid?
Yes.
Absolutely, ma'am. I mean, now it's part of the guideline also. Yes.
Jairani wants to disagree. Very good. Yeah.
No, not disagree. I want to agree with Chinmayi. How come I can disagree?
No, only if you disagree, I want you to put up your hand. Otherwise, if everybody agrees.
That is the South Indian way of saying yes.
Yeah, okay, fine. Uma Maheshwari, madam, you want to disagree? Dr. Radha Lakshmi or Dr. Aruna? Anybody wants to disagree with what Chinmayi says?
No, madam, we are not disagreeing, madam.
So, universal screening for all. You do not want to do a risk-based screening, right?
No, madam, universal screening.
You have to remember that the recommendations are totally controversial because there's a group which says you should do universal screening and Spirov stands tall there. 2020, they came out in the textbook itself that you should do a universal screening. Foxy GCPR is for universal screening. The Indian Thyroid Society is for universal screening. But remember that the big bodies, the ACOG, the RCOG, the Endocrine Society, the American Association of Endocrinologists, and the national guidelines of the Indian government say you should go only for a risk-based screening. And as usual, there's somebody who's equivocal, American Thyroid Association, who says it's your choice, whether you do it universal or risk-based. And there are 2 trials which actually brought out this thinking that universal screening is not needed. The controlled antenatal thyroid screening or the CATS trial of 2012. And there was another study with the Maternal Fetal Medicine Network in 2017. They found out that whether you treat or not a subclinical hypothyroidism after screening, it doesn't make any difference to the newborn. There's no difference in the neurocognitive development. And they followed up the children for almost 9 years and they did not find any difference just because it was treated. I think somebody has to mute themselves.
Uma Maheshwari, ma'am, I think you'll have to log out of one of the devices. Otherwise,
Yes,
there will be.
madam, I have logged out, madam.
Yeah, 1 minute. And Dr. Jairani, can I ask you, what test do you usually do for screening? Only TSH or you do a full profile?
I always, it's better to do a full profile.
What all you do?
I do a free T3, T4 and the TSH. And also, and if it is a high risk women, like a BOH or a bad obstetric history, women who had a previous miscarriages, previous obstetric loss, I will prefer to do even a TPO. But usually the recommendation is not.
So it's a rich group of patients. So straight away for antibodies, you go along with the...
No. Not for routinely, we don't do. Routinely, I prefer to do Yeah, it is. Yeah.
Anybody wants to agree or disagree? Disagree only I want. Anybody wants to disagree with
the recommendation? By the recommendation, you can go with the TSH alone, but it is better.
We do only TSH for screening.
Okay.
If the TSH is abnormal, then we go for the TPO antibodies, as well as suppose it is subclinical, then we go for the TPO antibodies, because then we decide whether we treat or we don't.
So that's a stepwise screening you want to do, right?
Yes, ma'am.
Dr.
Yes,
Uma, what is your opinion on that?
I do a TSH.
Madam Jainani madam said very clearly she will do only for a high risk individual like a BOH or has got any other high risk factor. She will go for an antibody testing. Chinmayi says she will do only a TSH irrespective of whatever the clinical history, and then if she finds out that the TSH is equivocal in the form, it is subclinical, then she will go for an antibody testing. What is your opinion on that?
I go for a TSH and a T4.
Ma'am, you will have to log out of one of the
log out
devices.
of the other.
You leave
No,
that
madam.
webinar.
One device for the madam in the panel. Seri. Okay. Yeah, now it's fine. So, நீங்க வந்து TSH you will do, then
TSH and T4, madam.
Okay. Free T4 or total T4?
Free T4, madam.
Free T4. Okay. Anybody else wants to agree or disagree? Dr. Radha? Yeah.
Madam, routine for screening, routinely I used to do TSH only, madam.
Only
Already
TSH.
for the woman who is taking already L-Troxin,
Okay.
I'll do T3, T4, TSH. And if the history of bad obstetric history and first time.
See, already if she's taking L-Troxin, why do you want to screen her?
I want adjusted dose, madam.
So adjust the dose.
Because
So that
she's
is not
on
screening.
L-Troxin.
That is monitoring. That is monitoring. That's not screening. Yeah.
Okay.
So, Dr. Aruna Suman, would you like to say something? You're not
Yes.
joined.
In our hospital, I work in a government setup. We do T3, T4, TSH. Free T4, TSH also.
Free
Yes.
T4. Okay.
Yes.
So your government hospital is able to afford all the three then?
Yes. Yes.
Okay, so actually the sequence of screening, you do only a TSH. If it's normal, you leave her alone. If she's got a high TSH, a free T4 is definitely needed. And if there's a low TSH, you will also do a free T3 because there's something called T3 thyrotoxicosis, which you can miss if you do only a free T4. So depending on the TSH level, if it's high, you will do only a free T4 because you need to know how much hyperthyroid she is. And I'm sorry, how hypothyroid she is. And low TSH, you will need to rule out T3 thyrotoxicosis also along with T4 thyrotoxicosis. And suppose you suspect a pituitary disease, or as Dr. Jairani said, you can modify to your clinical requirement. And suppose it's a child or it's a young person, adolescent, it's better if you do a TSH with free T4 even at the start, so that you don't miss out on a pituitary dysfunction also causing a thyroid disorder. And these are the levels which are taken as normal during pregnancy. 0.1 to 2.5 in the first trimester. Second and third, it will be 0.2 to 3, and third will be 0.3 to 3. It's very easy to remember. But there's something you have to remember, that is, you do not test for thyroid dysfunction during an acute illness. And that's because the acute illness can change your reports of thyroid dysfunction when you do it, so that you avoid acute illness, and then you do it when she becomes disease-free. And the testing for anti-thyroid antibodies, already Dr. Jairani touched on that. Dr. Chinmayi, what is your thought on that? Anti-thyroid antibodies. You've done a TSH. When will you do an
in our
anti-thyroid
country,
antibody?
the incidence of autoimmune thyroiditis is very high. And therefore, checking for the antibodies always gives us a perspective, because if the antibodies are present, then the thyroid status might actually be changing and it can go into hypo very soon. So if it is a subclinical variety, for example, something we get like around 3 or 2.8 in the first trimester, then we would like to check for the antibodies for sure. Even if we get higher, like 5 or 6, and we know that the antibodies are present, we know that this is the one which needs to be followed up, because things can change later on.
Okay.
So presence of antibody is an important thing, so we would check.
So your indication will be a subclinical hyperthyroid when you have picked up TSH, which is high, right? Yeah.
Yes.
Anybody would like to add on, Dr. Jairani?
Yeah, even if she's a hypothyroid on medications, certain women needs to be checked for the thyroid antibodies, especially as we rightly point in an infertility women when she comes for a ART or an IVF procedure or an IVF pregnancy. definitely they need to be checked for the thyroid antibodies because they can have an associated other autoimmune problem which needs to be corrected along with the thyroid problem. So in that way, probably these
So
are
you mean to say if you check for thyroid antibodies, you will pick up the other antibodies also?
Yes, there are. It's not like that.
Yeah.
There is an indication that she can have an autoimmune problem along with that. So
But
she needs to be, the dosage has to be adjusted depending on her condition. Because if she is an infertility woman on an ART procedure or IVF pregnancy, it is better to check it because they may have the dosage.
Suppose it's high means how will you change your dosage?
So that depends upon the, see, for example, if she has a TSH normal and if she has a thyroid antibodies higher, then she's a case of a subclinical hypothyroidism because many a time during the pregnancy, because of the physiological changes, there is a possibility that she can have a variations in the TSH level as well as in her thyroid uptake as a renal clearance in the fetal, everything will be changing.
No, but the management will not change, no? But anyway, only
No,
when she becomes pregnant
there is
and
already there is a problem of a lowering of the TSH level during a normal pregnancy. So if we find the TSH level is low and the thyroid antibodies are higher, then we need to give her a supplementation at that time. So for that, I need to go for a thyroid antibody testing.
Chinmay wants to say something.
I just want to ask actually, ma'am, Jayarani ma'am or Jamila ma'am, I mean, suppose you see high levels of the antibodies, even if the thyroid level itself is not very abnormal. If thyroid level is abnormal, you will wait till it gets normalized. But if the antibodies are just high in a woman who's going for ART, would you actually wait till the antibodies have, reduced or become negative?
No, absolutely not.
No, we did not wait.
We did not, but we'll put a risk factor that we'll closely monitor her during the IVF treatment, and when she gets a pregnancy also, we will be looking into the thyroid profile. That is a very important thing. That we should
I'll make it very simple.
That should go is if you're giving the treatment, then the presence of antibody itself is not a big deal.
Yeah.
See, and I'll make it very simplified, Chinmay. Suppose a person has got a TSH which is abnormal, her T4 levels are free T4 levels are normal. She's subacute because she's just tilting to one side, not gone into full overt hypothyroidism. So you will do an antibody testing, and if the antibodies are high, you'll keep a watch on her. You will not put her on L-Troxin just because she's gone into a higher range. Because when you start treatment, estrogen is going to rise so much during your stimulation protocols and during your transfer protocols. So this estrogen will tilt her because the TBG, the bound hormone becomes more. So the free levels of hormone available for the body becomes lesser. So that will cause problems to the fetus. That's why you keep her under great watch if she's got antibody positive, but you will not change a dose of L-Troxin because that will not help her at all. You'll just keep a watch over that because she may tilt towards an overt hypothyroidism when she becomes pregnant or during her protocols. So that's why you keep her like that. So that's the significance of antibodies.
Yes.
And so if she's asymptomatic but the TSH is high, that means she's subclinical. So you check for antibodies there always, because if she becomes positive for antibodies, it means she'll become hypothyroid in the next 1 year by 20%. So there's a chance of increasing. And Foxy 2019 has said very clearly, even if they are euthyroid, but they've got autoantibodies positive, you will put them on the same monitoring protocol during pregnancy as you would do for a lady who is overt hypothyroid. So you know that's when because you need it for the baby till 20 weeks of gestation. So you'll put her under great watch because you do not want her to become overtly hypothyroid. And it's better, as Dr. Jayarani said, to treat patients who are going for IVF because you know that the estrogen content is going to be very, very high in her, and that's going to tilt her towards a overt hypothyroid. I hope that clears the point there. Yeah. So suppose you have antithyroid antibodies positivity, the therapy according to Foxy is you will recommend if the antibodies are positive and she's got a TSH between 4 to 10. So that means she's becoming higher and higher. So she will go into overt once she becomes pregnant. But for a lady who is antibody negative and has got a TSH between 4 and 10, you can consider it will not alter much according to the trials, the baby's outcome. And suppose she's got a positive antibody, but the TSH is not so high, 2.5 to 4, the adult, the non-pregnant range. If she's around that and antibodies are positive, you'll think about starting L-Troxin, but you will not start. But keep a watch over all these women because these are the ones who can go for more of overt hypothyroid when they become pregnant. And how do you classify hypothyroidism? Can I ask Dr. Uma Maheshwari?
Yes, madam.
This we have talked about, but I would just like to summarize.
So classification of
hypothyroidism in pregnancy.
Hypothyroidism in pregnancy, it is actually subclinical, you can say, when the level is below, it is actually in the borderline, and we don't have to treat the patients for that. We have to keep monitoring them. And overall hypothyroidism is that whether TSH level is actually around normal, but T4 level, T4 and T3, if the level is low, it is oral hypothyroidism. We have to treat them. And oral hypothyroidism, when the TSH level is more than 10, irrespective of the T3, 4, we have to treat the patient with thyroxine.
Yeah, thank you, ma'am. What are the common cause of hypothyroidism pregnancy? What is the significance of goiter? What is the significance of nodules? Can I ask Dr. Vidya Lakshmi? Radha Lakshmi, ma'am, sorry, sir. Dr. Radha Lakshmi.
Common causes of hypothyroidism in pregnancy, in some places iron deficiency, and in some places Hashimoto's thyroiditis.
Okay. Suppose there's a nodule or a goiter, will you evaluate during pregnancy?
Nodule, we have to evaluate, madam. Actually, biochemically,
yes.
and because something we can evaluate, we can do FNAC is not a contraindication in pregnancy.
Yes, yes.
And the surgery and all we can postpone, depending upon the clinical situation.
So nodules will need to be evaluated. Do not take them lightly just because she's pregnant. Goiter also will need a profile and a scan also if needed. But if the thyroid functions normal, do not treat that goiter at all. After delivery, you will see, because most of the times it may regress also. Because during pregnancy, there is a 30% increase in size of goiters normally. And regarding nodule, the guideline from the American colleges, you will take a history, examine her, ask for a TSH testing. Ultrasound of the neck is mandatory because it will detect nodules which are larger than 0.5 centimeters. And during pregnancy, 90 to 95% can be benign, but remember it can be malignant also. 5% risk is there. But always remember, for a palpable thyroid nodule, you will take into consideration the gestational age of the baby and the size of the mass. And how do you treat hypothyroidism in pregnancy? Can I ask Dr. Aruna Sumu?
Aruna is traveling. She had a message.
Okay,
she's traveling. Her internet is
Madam,
not
you can take. Jairani, madam, you can take.
Yeah. So usually the drug of choice is the levothyroxine. We usually give 1.6 to 2 micrograms per kg body weight. It should be given either as a, as a split dose. You can split it up. Make sure that you give it.
Why split it up?
No. In the morning, you have to give it an empty stomach before breakfast. That is always there. But sometimes when they have even a severe hyperemesis, you can give it even along with food that has been given. And usually, if a woman is already taking thyroxine, if she's a known hypothyroid, then you have to increase up to 30%, 30 to 50% of her previous dosage.
Madam, that will go later during pregnancy. This is basically for when she is starting therapy. Okay, perfect. And Government of India guidelines is very clear for even subclinical hypothyroidism. And suppose she is having a level of TSH between 2.5 or 3 to 10, 25 microgram is quite enough. More than 10, give her 50. These are all for subclinical hypothyroidism. And suppose she's less than 10 when you're starting, you can stop after delivery. And if she's more than 10 when starting, you'll need to continue after delivery because these people will go for overt hypothyroidism. And already on treatment, you should continue during pregnancy. How do you monitor? Can I ask Dr. Radha Lakshmi?
Actually, monitoring with the TSH, it takes time, madam, 4 to 6 weeks time to settle. So we can monitor both with TSH and with free T4 as well. And if you have diagnosed the case in the early pregnancy, we have to repeat TSH and free T4 at 22 to 24 weeks and also at near term because the dose has to be increased. Mostly
change according to her levels, but actually you can monitor only with TSH levels. Once for diagnosis you will need free T4, but for monitoring you need not have free T4. You can just do with TSH alone because it makes it more expensive. You're going to you're not going to change your treatment based on the free T4 levels. The treatment is going to be based on the ranges of TSH during pregnancy, which will be 2.5 in the first trimester and 3 in the second and third trimester. And alterations of dosages, this also has been put up. And Dr. Jairani, you can take this now. The increased need during pregnancy, which you talked about earlier.
Yeah, definitely there is an increased need during the pregnancy because of the fetal maturation. As you pretty well know that there is during the pregnancy, the physiologic changes of these thyroid hormone greatly. The thyroid gland changes a lot. It increases because of the beta estrogen have a similar effect as a thyroid stimulating factor TSH. It acts on the thyroid to make it enlarge. And also the estradiol level also makes the thyroid binding globulin to go down, and thereby there is an increase.
Actually, it increases the binding globulin. So it will increase the
increases
bound
the
hormone.
binding globulin, thereby there is an apparent lowering of the TSH level. And there is an increased clearance in the renal clearance, both the fetal as well as the maternal. So it automatically goes down. So that is why even a non-pregnant women, when you compare a pregnancy and a non-pregnancy, the TSH level will be lower in a pregnant women. So that is why we have to give importance that the subclinical thyroid may become overt during the pregnancy.
You meant thyroxine actually, not TSH, thyroxine.
Thyroxine, yeah, thyroxine has to go. So we need to give her a proper treatment that way.
So actually, you should increase 25% of the dose which was getting pre-pregnancy, which is already on treatment. And can I ask Chinmay now, fetal thyroid function? What is the effect of thyroid hormones on that?
The fetus is dependent on the mother for quite a long time. I mean, at least in the initial part of pregnancy. So the thyroid correction has to start very early in pregnancy because it's all transplacental transfer from the mother to the fetus. So in conditions where the mother herself is hypothyroid or the antibodies are present, or whenever, the mother is on anti-thyroid drugs, or those are the things where the fetal thyroid will get adversely affected. Under routine circumstances, as has been seen, which is why the various bodies differ in their recommendation about universal screening, because it is not like under routine circumstances it is going to cause hypothyroidism, because the worst part of congenital hypothyroidism, something like cretinism, which was very, very common earlier. So we don't see that very often. We do see problems if the mother is on anti-thyroid drugs. I mean, mother herself is hyperthyroid. But otherwise, the fetus is dependent on the mother, and therefore maintaining maternal eustasis is important in terms of hypothyroid.
So would you advocate universal neonatal screening for thyroid as for the mother?
Yes, absolutely, because that is again another ball game. There could be conditions where the fetus itself does not show that many features, but if congenital hypothyroidism is missed in the newborn period, the manifestations will be slow but very, very long standing. And therefore, it has to be part of the newborn screening program.
So according to the Indian Society for Pediatric Endocrinology 2018, you will do screening for every newborn using cord blood, or if you missed it in the cord, you can do it 48 to 72 hours. It's better that you don't do a screening between 48 to 72 hours, because after birth, the TSH starts increasing within half an hour, and it falls to baseline after 48 to 72 hours. And neonates with if TSH more than 20, you will be calling the patient again for a reconfirmation. And if the screening TSH is more than 40, immediate confirmation has to be done with a venous estimation of T4 and free T4. And for mild elevation, you can do a second screening at 7 to 10 days after birth. And preterm and low birth weight infants, ideally they should be screened at 48 to 72 hours postnatal age instead of the cord blood. That's one recommendation. And when your baby is sick and in the NICU, please do the screening after 1 week. Don't do it in the immediate postpartum period. So newborn screening is a must, as Chinmay said, because you should not miss this thyroid dysgenesis, which will go on to congenital hypothyroidism. And when you do a early screening and treating the babies, you will be avoiding that mental development which can be abnormal in these babies. But remember, there's a group which may not even respond to the treatment you're giving because of transcription factors there. So can antenatal diagnosis of congenital hypothyroidism can be made, Chinmay? Any treatment available for that?
Yes, ma'am. The thing is, whenever the mother is hypothyroid or we see any goiter, so if the mother is hyperthyroid, we actually keep the fetus on follow-up. But sometimes, rarely, we do see fetuses with, swellings in the neck, and that is how to diagnose it. We actually do a cord blood sampling. I mean, umbilical cord blood, and send it. The biochemist will tell us whether or not it is falling in the range of hypothyroidism. The problem is the treatment, because it is actually a very simple treatment. You can take IV thyroxine and put it intra-amniotic, and the fetus will swallow it and it will be fine. But getting the IV thyroxine has been our challenge. In fact, we have not been able to provide it to any of the patients that we diagnosed. Some of them went on and delivered, and luckily it wasn't very bad and things were good postnatally, but some of them terminated because there were huge goiters and we couldn't find the medication. So that was the problem.
So, Uma Maheshwari madam, regarding overt hypothyroidism in the postpartum period, you manage during pregnancy. Now she has delivered. She was a overt hypothyroid during pregnancy. How will you manage her in the postpartum period?
I'll wait for 4 to 6 weeks, madam, and then repeat the sample, PSH sample, and we'll get the result.
Okay, but you can go back to the pre-pregnant dosage instead of the 30% increase which you are given during pregnancy, and you can actually go back to the previous dosage, but recheck the TSH after 6 weeks, and then an annual checking is needed. And for a subclinical hypothyroidism, you have given her L-Troxin during pregnancy. So how will you treat her in the postpartum period? Dr. Uma?
I will wait, madam. Actually, I'll wait for 4 to 6 weeks. I'll continue with the dose, and after the rechecking, I'll stop the dose.
Yeah, because when there's less than 50 micrograms which are given during pregnancy for subclinical hypothyroidism, because the estrogen goes off after delivery, she goes back to a regular menstruation. Then you can actually stop the dose, but check her TSH and keep her under monitoring, because she can anytime tilt towards a overt hypothyroid. And suppose you treated a person who had thyroid antibodies during pregnancy. Dr. Uma, how will you manage her in the postpartum?
Madam, we can wait, madam. Again, we can wait for the patient because the baby is being delivered. So we can wait for some time and recheck and again start if it's necessary.
So thyroid antibodies.
For sake of antibodies, we don't have to start the treatment after postpartum.
Perfect. And there's something called postpartum thyroiditis, which says because of fetal condition, which is causing a presence of fetal cells in the maternal thyroid gland. And this you have to always check for in a patient who comes with complaints of hypothyroidism in the postpartum period, because these people will be an association. As Dr. Jairani mentioned earlier, there's an association with other autoimmune diseases. So these patients have to be seen very carefully, and they would have had an episode in a previous delivery. They will probably have insulin-dependent diabetes, history of early miscarriage, thyroid antibodies. And these patients, you will check TSH at 3 and 6 months, and always keep her under checking for at least annually for the next 5 to 10 years. And do all of you think that we should treat subclinical hypothyroidism? Different guidelines are giving us different things. Can I start with Dr. Jairani, ma'am? Do you think we need to treat subclinical hypothyroidism? Does it make a difference to you? I'm not asking about the guideline. In your practice, has it made a difference when you treat subclinical hypothyroidism?
Yes, because most of my patients are infertility workup conceived patients with a high risk also, and also very precious pregnancy. So never I leave them, even prior to the treatment itself, we check for it. And even if they are subclinical or a little lower level, we treat them, because definitely once they get the pregnancy, they will be automatically going for an overt, and that may cause a miscarriage and all the complications.
So isn't that an assumption that she will definitely go and we are starting?
Yeah, definitely, because it has been
have you not given somebody and seen whether she becomes hypothyroid later? Did you check that?
We don't give a chance, because you can't test her, because every patient is coming for a baby, and it's very difficult to
justify if something goes wrong.
Do the trial. You can't do a trial. So you always, because never, even if you treat her, even a little of an increased thyroxine will not harm the baby. Whereas if you make her hypothyroid, then she may go in for all miscarriages and pregnancy-related complications also will be more.
Dr. Uma?
Madam, I'll wait. Madam, I won't treat. Madam.
You won't treat subclinical. Okay. Can I ask Dr. Radha Lakshmi?
I do treat, madam.
You treat. So 2 to 1. Chinmay, you will give the verdict now.
So, ma'am, whenever there is subclinical, because we don't deal with the ART situation, which is very like a kind of premium situation, we always check the antibodies. If antibodies are present and she is subclinical, we start treatment. If antibodies are absent, we repeat the TSH after 1 month. And suppose there's a rising trend of that TSH, then we treat, on otherwise not.
Chamla,
now you will change your opinion.
Chamla, the treatment part is what we mean by it. It's automatically thyroid antibodies has to be checked. That is the. I mean, we always looked at treating the subclinical only with the thyroid antibodies alone.
You
That is how
started with
we
that
will-
only when you said
Yes.
that a high risk condition you will do.
Yeah.
Dr. Uma, now you will change your idea, or it will be subclinical, you will not, but you will check for
No,
antibodies.
depending
and
on, we have the antibodies positive,
Then
we
you
shall
do.
really,
Okay,
surely
You
treat.
meant that when there are antibodies negative and she's
Negative,
subclinical
yes,
with
ma'am,
only
yes,
TSH, you will not treat. Perfectly.
Madam,
So-
if antibodies are positive and even if the patient is euthyroid also, we have to treat, no?
If she is antibody positive, TSH is on
Even
the
if
rising
TSH is
trend.
normal,
Rising trend. If TSH is normal, you will think before starting. But if the TSH is also on the higher side and you've got antibodies positive, it's better that you treat. Okay, ma'am. Radha ma'am, would you like to say something else before we, because I think I'm going to finish now. Dr. Radha?
myself.
You agree? Yes, ma'am. You agree with all of them, or you want to add something, Amas?
No, today only I read in Williams that even if the patient is in euthyroid state, even if the TSH is normal, if the antibodies are positive, we can start levothyroxine.
That's what, ma'am.
Yeah,
The 2.5 to 4. That which is a very, like nobody knows what is happening. 2.5 to 4, and she's antibody positive, and she's going for infertility. She's going for infertility treatment. It's better that you start L-Trox. There's no doubt on that. But I'm asking, in your practice, what is this thing? Because Williams is 100 things there.
I'm starting, ma'am.
Okay. So why you should treat subclinical hypothyroidism is you can prevent a goiter formation which can happen when the patient is subclinically hypothyroid. It will improve the physical and mental well-being when she is treated. It will improve the cholesterol profile, and it's a known risk factor for coronary artery disease later on. And iron deficiency anemia will respond better when thyroxine treatment is started when the patient is subclinically hypothyroid. And as Dr. Jairani said, recurrent pregnancy loss are quite common in subclinical hypothyroidism. And that's why you need to treat these patients even when they are not overtly hypothyroid. The take-home messages will be universal screening is recommended for all pregnant women. Pre-conception screening will be much better because you can always correct before she becomes pregnant. Screen with TSH and free T4 as much as possible. She's got a high TSH and a low T4. She is overtly hypothyroid and levothyroxine should be started. She is a normal T4 and TSH is about 10. She is also a overt hypothyroid and you start treatment. If the T4 is normal and TSH is between 2.5 to 10, consider therapy as in high risk conditions. Monitor every 4 to 6 weeks with TSH levels. Maintain the trimester targets. If she's already being treated for hypothyroidism, during pregnancy, will increase the dose by 25%. Universal newborn screening is advisable by all the organizations. In the postpartum period, go back to the original dose. But in a subclinically hypothyroid patient where you started L-Troxin during pregnancy, you will consider stopping and monitoring the TSH after 6 weeks. Thank you so much. I'm not going into hypothyroidism in pregnancy because all of us will become hypoglycemic. Thank you so much for a patient.
Thank you, Tamila, for the sweet and crisp.
Madam,
Thank
you
you
I finished
very
on time. I finished on time.
Yeah,
as Dr.
yeah,
Jairani
Dr.
asked.
Sharmila, who can moderate this session better than you, with a full smile and loving heart and in a marvelous way. I should congratulate you and the wonderful experts, Dr. Chinmay Ratha, madam. You have agreed and for this and gave very wonderful, very intelligent inputs.
Thank you, ma'am.
Regarding this, Dr. J.M. Kannan, madam, is also there. Madam, thank you for being there. All the panelists, I'm obliged by your presence. Now the time is for the vote of thanks.
I was sitting there throughout, Kanchan, the minute I joined, but in between I put off the video because I was moving around for tomorrow's journey to Kanyakumari.
Oh, ma'am.
I'm going
Hats off to you.
tomorrow.
Hats off to you.
I was enjoying Charmila's question, Chinmay's expertise, Jairani's confidential arguments.
Thank you.
Because you are
the books, because this webinar has given a chance for her to look into the latest edition of Williams.
Yes.
All those things I am enjoying.
The webinar has made everybody to read, madam.
And then I really thank you before you give the vote of thanks.
Thank you,
Jayam Kannan, Ramani Devi, Charmila, we three are there.
Madam.
We are this. I'm so happy. about
All are from the South only.
all
Tamil Nadu.
spoke
Mostly Tamil Nadu, madam.
From
Virudhunagar,
same society.
Virudhunagar, Srivilliputtur, Trichy, everything is there, ma'am.
And they
All
gave
are there.
very good inputs.
And
Made us
Chennai is very close to me. And even
Yes,
after
ma'am.
sitting, I have been clarifying my ultrasound doubts with her. So thank you, Kanchan.
Yes, madam,
All the
thank
best
you.
for
We are obliged. I
To
am obliged.
Jairani also, all the best.
Thank
for
you, ma'am.
Jairani
Thank you,
also.
ma'am. Thank you for your
Good luck,
blessing.
Kanchan ma'am. Good luck, Jairani ma'am.
Madam,
Thank you. Thank you.
Thank you for your blessings. This is the time for official vote of thanks. I, Dr. Kanchan Sharma, give my heartful vote of thanks to all of you. The Tamil Nadu Society and the Kanpur Society has jointly organized this wonderful webinar, gave us very intelligent inputs and made us wiser after today's webinar. And first of all, my sincere thanks to our chief guests, Dr. Revati Raman and Dr. Meera Agnihotri madam, who blessed us and gave us wonderful inputs. Our guest of honors, Dr. Sampat Kumari madam, I am really obliged. You are the vice president. Even being so busy, you have joined us and blessed us, and even gave a wonderful talk on the GDM, and very crisp and very intelligent talk. We hear this GDM many times, but even then we gain too much of knowledge by your talk. Dr. Anita Singh madam could not join. Dr. Kiran Pandey, I am obliged by your presence and wonderful words of blessings. Our first talk was by Dr. Sampat Kumari madam on GTM, and the chairpersons, Dr. Jyoti Sundaram, Dr. Sundar Narayan could not join, Dr. Rashmi Ajit has joined, and Dr. M. Chandra. I am very obliged by your presence. The second talk by Dr. J.M. Kanan. She is there. I am really, madam, obliged. Your talks are always very refreshing, rather. We feel much energized after your talks, and your talk is on the lung and pregnancy. Really, I am really related with the lung because my husband is a chest physician. So that was really a wonderful talk. And the chairpersons, Shanti Rani could not join. Dr. Shanti Rani gave me message. Dr. H. Vanita was there. Dr. Radha Madhvi and Dr. Gayatri. I am thankful to all the chairpersons for the talk. And the third talk was by Dr. Ramani Devi. In spite of being busy in the cesarean section, she joined and delivered her talk. And her talk on hypertensive disease of pregnancy I always like, and every time with each talk I get something, new ideas and new point. Madam, thank you for your talk. And the chairperson, Dr. Jaimala, she was very well there and gave wonderful comments. Dr. L. Shanugawa, Diva was also, and she was not there, I think, the secretary of the Salim. And Dr. Dharamraj could not join. Dr. Uma Brinda was there. And I'm very thankful for your presence. And the next talk was mine on the pro-fertility diet. Dr. Melati could not join. Dr. Lakshmi Prabha, I am very thankful to you for your presence and wonderful comments. Dr. Sujata, I think, could not join. The next talk, the panel, wonderful panel. I should congratulate Dr. Charmila madam. Your panel, as I have heard and seen many times, is always fulfilled with the knowledge and very crisp and message giving always. And in a very short time, I can congratulate you. You have covered all the important points involving all the panelists.
Thank you.
Our experts, Dr. Chenmay Ratha, madam, you did a wonderful job, and being expert, really, you showed that you are expert and you gave your expert comments. And Dr. Suman, madam, Arna Suman could not join because she was busy somewhere traveling. Dr. Jayam Kanan, madam, we were always there with your interactions and expert comments. Thank you for joining. Dr. Poon Gothi, madam, she was, I think, not there. Dr. Radha Lakshmi, madam, is there, still there. And thank you, madam, for your wonderful inputs. As a panelist, you did a wonderful job. Dr. Jasmine was not there, and Dr. Kalpana became busy. Dr. Mary Annie was not there. And last but not least, my thanks to the Dr. Vanita is there, still there. Thank you, Dr. Vanita. And last but not least, my sincere and thanks to these two wonderful girls of this pharma company, Dr. Sahiti and Chitrakala. Both did a wonderful job, always with me day and night, arranging the CVs and preparing the flyers. Thank you, Sahiti and Chitrakala. You did a wonderful job. Thanks a lot. Thank you, everyone.
Thank you, ma'am.